Morning, everybody. I'm just doing a microphone test, but also to say start in five minutes. So final drinks and sort yourselves out, ready to go. Thanks a lot. Morning, everybody. I'm just conscious that the clock on the wall is 2 or 3 minutes ahead, but we try and start on time, and I've got 9:14 exactly on my clock now, so 1 minute to go. So start very shortly. Thanks a lot. Okay, good morning, everybody. And are we ready to live stream? We are indeed. So, welcome everybody to our September ICB board meeting. Welcome to Berry, as always. Just a reminder to everybody that we are live streaming this morning. Too many guests today to give individual introductions, I think, but welcome to you all. Welcome particularly to Jack's family. We really appreciate you being here. Welcome, of course, to members of the public. Apologies for absence. Tom, I've got 4, I think. Susanna Howard, Richard Watson, but Narinda, you're deputising for Richard. Caroline Donovan, but Kath, you're deputising. And Nick Hume, Adrian, you're deputising. Any more, Tom? Or got those? Okay. We are still waiting a couple of colleagues to join, but we are quorate, so I'm keen that we continue because of the time pressures today on this important agenda. We have a number, in fact, I don't think we've ever had a greater number of questions from members of the public today, so too many for me to go through now. But what we're going to try and do is deal with those questions at the appropriate time on the agenda, and those that we don't deal with, we will capture at the end during the time that we always allocate for questions from members of the public at the end of the meeting. So, colleagues, if we do miss any of your questions, hopefully it's because we're going to capture them at the end, but please do raise them as appropriate. So, next item is declarations of interest. So are there any declarations of interest or potential conflict of interest with any agenda item? And I think Ewan, you're going to raise one.
Yes, it's just to note that obviously a significant portion of the care described in item 4 was at West Suffolk Hospital, which I'm the Chief Executive.
Okay, thank you, Ewan. Any other declarations of interest, Ed?
Yeah, in relation to the same item, I was Chief Executive of the CCGs during the time in question, and there are other directors around the table who may want to declare their interest.
Yeah, should we take that as noted for all directors of the former CCGs? Maddie, did you want to come in there?
To confirm that I was the Chief Operating Officer for Ipswich and East Suffolk CCG. Thank you.
Okay, thank you. Any other declarations of interest or potential conflict of interest other than those of which we are aware, of course? All done, thank you. Okay, so item 4 on the agenda, a really important item, of course, the independent investigation report into the death of Jack Last. So I'm going to go to Andrew in a moment to introduce this, but let me tell you how I hope that we might be able to run this item. After Andrew has given his introduction, we're then going to go to Darren Thorne, who will take us through the report. There'll then be, for Jack's family, if you then want to come in, you're welcome to, or you can come in at the very end. Actually, if you wave to me at any point, I'll try and bring you in at any point. We'll then have questions from the board, and then we already have at least, 10 questions from members of the public that I think, Ruth, you're going to read out, and Andrew is going to attempt to answer. And then I'm going to come to Ed to summarise. And again, for Jack's family, you're welcome to come in at the very end as well, if you wish. So that's how we're going to try and run this first session. And with that, Andrew, over to you.
Thank you, Chair. So, as you all know, the first paper on the agenda is the report of the investigation into the death of Jack Last. And before we get into any of the business of this, I want to extend my deepest sympathies to Jack's family for what's happened. I know that everybody around this table as well will join me in saying that we are utterly sorry for the death of Jack and the effect that will have on you and on your extended family as well. So please, if you're able to accept that apology from me. So on the 20th of March 2021, Jack was invited to book an appointment for a vaccination against COVID-19. He attended for that vaccination on the 30th of March 2021. And on the 9th of April 2021, he went to West Suffolk Hospital with headache and visual disturbance. And by the 20th of April 2021, he had died with cerebral venous sinus thrombosis and vaccine-induced thrombotic thrombocytopenia. The word tragedy is a cliche, but cliches are so because they happen often. And this is truly tragic. And I think we all have to accept that. And it's doubly tragic because following investigation, we've identified that Jack's death was preventable. So in May 2021, the Suffolk CCGs, which are the predecessor organisations to this one, commissioned an independent review of the circumstances around Jack's death from Vicerim Elias, which is an independent investigation organisation. And I've said independent twice, and independence was crucially important to us at that time, because we needed this investigation to be utterly absent from bias, to be objective, and to tell the truth. Darren will describe how the investigation was conducted, but Darren and his colleagues made efforts to engage with Jack's family so that we could be sure that what the investigation examined didn't just look at the questions that we wanted answered, but also the questions that Jack's family wanted answered. Darren's going to go through the results of that with you, but before he does, the ICB fully acknowledges the findings of this report in the investigation and fully accepts the recommendations that were made. We can't ever prevent all medical errors, but we can prevent these errors, and that's what we're going to do. In terms of the future, the next step for us is to set up a task and finish group comprising representatives from primary care, from the local medical committees within Suffolk, from NHS England and other interested parties, to really look into the findings from this report and consider how we can learn, how we can reflect on the findings, and how we can enact not just the 4 recommendations that Darren and his colleagues will tell you about in the next 10 to 15 minutes, but also any other learning we identify from this report, including how we work with families and wider networks of people that die. Then I'm going to pass over to Darren, who was the author of the report and who works in the company Vicerim Elias, to describe how the investigation was conducted, what the findings in the investigation were, and what recommendations he made. And then, as the chair has described, there'll be opportunities for questions after that.
Thank you, Andrew. And on behalf of the investigation team, we also offer our condolences to the last family. So as Andrew has described, we were initially asked to do an initial investigation in July 2021, and that led to a full investigation being commissioned in September 2021. We identified 12 key lines of inquiry, which I'll cover in my discussion. There were 24 stakeholders, including local, regional and national organisations. This made this a very complex and detailed investigation. They included organisations such as NHS England, both nationally and regionally, the British Society of Haematology, the Medical Health, so the MHRA, and many other organisations. We spent a lot of time with the last family at the beginning, listening to what they had to say, understanding their perspectives and their opinions, and we continue to engage with them throughout. And hopefully we've answered as many of their questions as it's been possible to. So in terms of reference, I'll just The scope of the investigation started with why Jack was called for the vaccination, out of cohort and out of time for his age. We then went on to look at the care and treatment once Jack became ill through to his death. And then, unfortunately, Jack received an invitation for a second vaccine once he was deceased, which further upset the family. In terms of the investigation, we received evidence from 23 organisations. As I've mentioned, we met with Jack's family on several occasions throughout the investigation. In total, we had 328 documents that we needed to consider. We had over 35 meetings and interviews with individuals that provided care and treatment, but also helped us understand the systems and processes that went around some of the issues that we identified. And we also observed Jack's inquest. In terms of the independence of the investigation, I was the lead investigator and I established an expert panel. That panel consisted of an independent consultant haematologist, an independent consultant neurologist, an independent consultant neuroradiologist, a consultant interventionist, a senior GP advisor, and we also had support from a patient safety specialist, an A&E operational management specialist, an independent medical director, and an independent director of nursing to have oversight of the investigation. So there were 12 key lines of inquiry that we established. The first was the approval of the vaccine. We then looked at the commissioning of vaccine delivery. We looked at the identification of vaccine-induced thrombocytopenia, the deployment of the vaccine. We then went on to look at the vaccination invitation and delivery process, the response to the incident, primary care management, NHS 111 assessment and referral, GP in the community, that's at the front door of the A&E, the treatment and care that was provided at West Suffolk Hospital, the treatment and care that was provided at Adam Brooks Hospital, and then the recording of Jack's death. The report is 125 pages in total, and it provides a context of the pandemic, approval of the licensing and vaccines. It addresses the National Vaccine Delivery Programme and describes the local arrangements in place in Suffolk for vaccine delivery. It looks at the identification of vaccine-induced thrombocytopenia, both internationally and domestically. Within the report, we provide a detailed chronology of events in terms of Jack's invitation, the first indication that he had an adverse reaction, his first contact with health services, his inpatient stay, and then his transfer to Adam Brooks. We then go on to provide conclusions and recommendations, and that's supported by 14 appendices. So the outline of the key events that occurred in this incident. As Andrew said, Jack was invited on the 20th of March 2021 to take up the vaccine. He duly booked an appointment and received his vaccine on the 30th of March at a local vaccination centre. 7 days later, on the 6th of April, Jack began experiencing severe headaches and vomiting and some visual disturbances. 3 days later, on the afternoon of Friday the 9th of April, Jack called NHS 111 and he was urged to attend the emergency department at Suffolk hospitals as soon as possible. On arrival, Jack was assessed by a GP who concluded that his headache wasn't a migraine and should be referred for a neurological review and scan for suspected CVST, that's a cerebral vein sinus thrombosis. Jack was referred to the ambulatory emergency care unit at West Suffolk Hospitals, where his blood test identified some abnormalities consistent with the presentation of BIT. Later that evening, he had a scan, which was remotely reported on and incorrectly reported on as having no acute abnormalities. The following day, on the Saturday, a CT venogram scan was undertaken and the report documents appearances were in keeping with the CVST and VIT. The next day, the Sunday, Jack was transferred to Adam Brooks, where he received care and treatment for a further 2 days before he subsequently died on Tuesday, the 20th of April. One of the key questions we sought to answer in the investigation was Jack was a 27-year-old healthy male, and why was he invited for the vaccine on the 20th of March 2021? The story starts 11 years prior, in 2010. Unbeknown to them, one of Jack's parents had been given a diagnosis of COPD, which was recorded in their primary care record. 8 years later, in 2018, Jack moved to a new GP practice. In that same year, Jack moved house and completed a standard form informing his practice of his new contact details. The COPD diagnosis appeared in the list of designated people at risk being adversely affected if they were to become infected with COVID-19. And those with COPD, with the COPD diagnosis, were allocated to what was described as priority group cohort 6 for receiving the vaccination. In March 2021, at the same time, Ipswich and East and West Suffolk CCG were notified that they were to receive a high volume of short-life doses of the Oxford AstraZeneca vaccine. In addition, the CCG, and alongside every other CCG, was faced with a diminishing eligible population alongside a national wastage target of no more than 5%. The CCG took the decision to approve a search using a national algorithm for patients who were categorised to be in cohort 6. The primary care data team then searched for corresponding telephone numbers with the cohort 6 list to identify what was described as cohabitees. So they were looking for patients that had diagnoses that were described as at risk within cohort 6, and then they were looking for people that lived with those individuals. Jack was returned as a cohabitee because his parents' telephone number had remained on his record. Within the investigation, we looked at what the missed opportunities were. In primary care, we looked at the April 2010 diagnosis of COPD being recorded. And it was this diagnosis that put one of Jack's parents into cohort 6. A review of their clinical records from our expert advisor identified that there were no further reviews or active treatments for COPD after 2016. They further concluded there was no firm evidence of COPD, and the parent's chronic cough was thought to have been asthma-related and was diagnosed by a respiratory consultant in 2016. 4 years later, in February 2020, at their new GP practice, a nurse made an entry into the record stating, "Needs COPD removed, seen in respiratory department in 2016, not on regular ICS." ICS means inhaled corticosteroids. The nurse accepted the parent, from the COPD register as patient unsuitable. And what accepted means is that they're taken out of that cohort as not requiring a regular checkup for that year. On May 19, 2021, 7 weeks after Jack received the vaccine and 4 weeks after he died, both the asthma and the COPD diagnosis were resolved in the parents' records. This means it was no longer considered to be a current condition. Our expert advisor looked at the clinical records and could not identify any significant change to the parent's condition between February 2020 and May 2021. A subsequent query for cohort 6 was run after the resolve code had been applied, and it was confirmed that Jack's parent did not appear in that search. It's important for us to note, though, that in any other situation, in the majority of cases, the application of a residual diagnosis sitting on a primary care record would not likely to cause a patient any harm. We also looked at further missed opportunities within West Suffolk Hospital's NHS Foundation Trust. When Jack was assessed in the emergency department, his deranged coagulated blood results were consistent with someone presenting with VIT. However, he was placed on a migraine pathway. Our clinical expert and interventionist was of the view that with such a serious abnormality, a hematological specialist input was required, but it wasn't sought at this time. The incorrect remote reporting the CT scan on the evening of the 9th of April was identified the following morning, and at this point, hematological advice was sought. The time between the abnormal blood results, which was 6:15 on the 9th of April, and the first recording of anticoagulation medication prescribed by the haematologist, which was 4:18 on the following day, was a delay of 22 hours. In the investigation, we considered other issues. We looked internationally at what was happening in relation to VIT. Between the 7th and the 15th of March in 2021, Austria, Denmark, Norway, Iceland, and many other European countries had started to report and identify links between the AstraZeneca vaccine and blood clots occurring in people who were receiving the vaccine, sometimes resulting in death. The use of the AstraZeneca vaccine was paused in those countries at that time. The day after Jack received his vaccination, which was the 31st of March, NHS England published updated guidance from the JCVI that the adult household contacts were to use a GP practice letter letting them know they were eligible for vaccine, along with documentary evidence of their address. If this had been in place at the time that Jack had his vaccine, it would have been identified that he wasn't living in the same house. On the 7th of April, 8 days after Jack received his vaccine, the JCVI advised that it was preferable that AZ vaccines should not be given to people under 30 years of age. Jack spoke with an NHS 111 call handler at 1:40 on the 9th of April. A clinical advisor called him back within an hour, and the investigation team has listened to both those calls. The clinical advisor carried out a detailed clinical assessment of Jack's symptoms, showing good professional curiosity, and spent time urging him to go to hospital as soon as possible. And he attended the ED at Bury St Edmunds. Other issues that we considered: West Suffolk Hospital undertook a patient safety review to understand the care and treatment that Jack had received, and this was shared with the investigation team and with the family. And we reflect on an important learning point for all healthcare providers. They should ensure any reviews are written in such a way that they're accessible in language and understandable in plain English, and need to be really considerate to its readership. The review of the report of the first head scan at West Suffolk Hospital was part of the radiological department's governance arrangements, and a root cause analysis was requested and undertaken by the third-party provider. However, this was disconnected from the hospital's patient safety governance arrangements, which led to it not being included in the patient safety review and led to the investigation team not finding out about it until some months later. One of the other issues we considered was around permission for publications of the case. Within the pandemic, it became regular practice for medics to write up case studies and submit them to the BMJ in an attempt to understand what was happening and to promote wider learning. And Jack was approached and gave permission for his case to be included because VIT at that time was an emerging condition. Jack agreed and signed an appropriate consent form, and the case study was subsequently published, although it's important to note that some elements don't reflect the outcome for Jack. Finally, when a patient dies, it's important that GP practices update their records in a timely way. In Jack's case, this didn't happen, and it led to an invite being generated for the second vaccine. This would have undoubtedly been distressful for the family. We identified 4 key areas for opportunities to learn: the importance of primary care coding of diagnosis in patient records, differentiating when a diagnosis is still active or should be considered resolved; the administration of phone numbers in a primary care setting. The current national form does not prompt or ask patients if there are any telephone numbers or details that they wish to be removed from their record. A third point is when a new disease emerges, how is guidance developed and disseminated nationally quickly, ensuring those who gatekeep access to services have the latest information? And finally, how clinical systems support the recording of deceased patients to ensure the personal demographic service is updated whilst enabling GP practices to continue to update and administrate a deceased record. And it's quite an important point because if there's ever an inquest, GP practices are generally asked for clinical information. And at the time of the investigation, we were told that if the record is closed, it's very difficult to extract that information. We therefore have made 4 recommendations. NHS England should consider developing guidance for GPs on how to move active diagnosis codes to resolve codes. NHS England should review its guidance to include a check for out-of-date decommissioned telephone numbers, and similarly for addresses. The Department of Health and Social Care should consider developing an MOU between national agencies, royal colleges and professional bodies to ensure that guidance on newly emerging diseases is coordinated and published as widely as possible and as quickly as possible. And the last recommendation is for all integrated care boards should seek to assure themselves that every practice has implemented the requirements of the data provision notice around recording patient deaths. Thank you.
Darren, thank you very much for that report. So could I just ask Jack's family any immediate response, or do you want to wait? You'll wait. Okay, thank you. In which case, any immediate questions or points from the board? Ewan?
Thanks, Will. On behalf of all of the staff who cared for Jack at West Suffolk Hospital, we're really sorry and would like to extend our deepest condolences. I can't imagine what you've gone through and are continuing to go through. This is a really heartbreaking and tragic story. There were clearly opportunities to start Jack on treatment earlier, and from your statement in the report, it's clear that he wasn't always treated with the kindness that he should have expected. I know that nothing that we can say can help with that, but I hope that you've got some of the answers you need from this report, but we're really sorry.
Thank you, Ewan. Any other immediate responses, questions? Otherwise, let's go to the questions from the members of the public, which we already have. Now, how we're going to do this, Ruth, you're going to read them out. Have you got a microphone down there? Yes. Okay, in which case, over to you, and we'll do it question by question, answer by answer. So, all yours.
Okay, thank you. We've received a number of questions on the independent investigation report into the death of Jack Last. All questions will receive a full response, a full written response. The content received falls into 3 main groups and are answered as such. The first is adverse reactions and patient experience. The second is information sharing, and the third is general. We have a question, first of all, from Charlotte Crichton, who wrote about the distress that can be caused to patients who receive an invitation to further vaccinations after reporting suffering an adverse reaction, noting that this happened to Jack Last's family, and that the independent investigation makes a recommendation about this issue. She asks, is it an IT issue that patients who have died or have experienced a life-changing adverse reaction can still be invited for further vaccinations? If so, how can this be resolved?
Thank you. Andrew?
Yeah, thank you. So as Ruth said, all questions will receive a full written response, but we will answer verbally where we can, accepting we may be able to answer some elements and not others. The answer to this question is that NHS England commissions the COVID-19 vaccination programme and all national vaccination programmes. And we will work with NHS England on the written answer to this question. We will also communicate the findings of the report around primary care data processes with GP practices to make sure that they are aware of their obligations and their opportunities to improve use of data.
Okay, thank you. Back to you, Ruth.
Charlotte Crichton also writes, what training regarding adverse reactions do medical professionals receive, and what training was given to medical professionals regarding COVID-19 vaccination adverse reactions, particularly those of an unknown nature, during the vaccine rollout in 2021 in Suffolk and North East Essex?
Thank you, Andrew.
So the general training of medical professionals, again, is commissioned by NHS England, but we will work with them on the written answer to this question. We'll also work with the Suffolk GP Federation and the Integrated Care Board vaccination team to collect this information as full, and details of the training provided during the COVID-19 vaccination programme in Suffolk and North East Essex during 2021 will be provided in the written response.
Thank you. Ruth?
Charlotte Crichton provided details of an FOI response she'd received from the government, which identified that the vaccine batch from which Jack received his vaccination appeared to have caused the most adverse reactions reported of any batch delivered in the UK. She asks, the report shows this batch had a short shelf life and clearly needed to be administered quickly to the public. Has Suffolk and North East Essex ICB or the investigation queried this as a potential link to adverse reactions with any public authorities?
Thank you. Andrew?
So the investigation report has already been shared with NHS England and the Medicines and Healthcare Products Regulatory Authority, but we will follow up on this by providing these batch details to them.
Okay, thank you. And Ruth, are you now moving on to Amy Keating?
Yes.
Okay, back to you.
Amy Keating shared the details of the tragic death of her son in 2022 while under the care of a hospital in Cambridgeshire. She asked, if there's nothing nefarious going on, why are you not honest and transparent? We all make mistakes, and that's called humanity. And maybe that's fine, but why all the ridiculous lies and cover-ups? We're not stupid. The first rule is do no harm. And a big second rule is speak the truth. Truth will always win.
Thank you, Ruth. Andrew?
So, Amy, I'm very sorry to hear about your loss. The Integrated Care Board commissioned this report from Sir Emelius so that it would be independent of bias and fully transparent, and nothing has been removed or covered up.
Thank you. Ruth, are you now going to do Jules Sirkin?
Yes.
Okay, over to you.
Jules Sirkin reported that she was suffering from ongoing health problems following an adverse reaction to a COVID-19 vaccine. She asks, was Jack given the leaflet containing the ingredients of the AstraZeneca injection, batch number 4120Z003, prior to him having it? Was he informed of the risks of clots, especially in the young? Why did they write, Jack died peacefully in his sleep, when the family say this is not correct? Why is the deadline for public questions so short?
Thank you. Andrew?
So, Jules, I'm very sorry again to hear about your health problems. The Integrated Care Board requests that questions are submitted in advance of the board meeting and following publication of the board papers, so that as far as possible full answers can be prepared. But despite this, from time to time, a verbal response still can't be fully provided. The comprehensive response to your questions will be provided in writing as described. However, at the time of vaccination, a link between blood clots and the AstraZeneca COVID-19 vaccine had not been confirmed. The number of cases of cerebral venous sinus thrombosis and vaccine-induced thrombotic thrombocytopenia following the vaccine was extremely small, and details were not well understood by healthcare professionals.
Okay, thank you. Ruth, are you moving on to Richard Griffin's questions?
Yes, Richard has asked 7 questions. Was information given to patients, as in Jack's case, on the ingredients contained in the AstraZeneca COVID vaccine? Were Jack and patients informed of the clot risk and adverse reactions in the COVID-19 vaccines? After the terrible death of Jack from the COVID-19 vaccine, how was this communicated to the NHS and TCG gold level meetings so this information could be disseminated strategically and stop others taking these vaccines, particularly if they had no underlying health issues and were fit and well, not immune compromised? Were GPs and other medical professionals informed? GPs operated mainly in a telephone capacity during lockdowns. Could they have missed blood clots or adverse events due to this? Why did Germany stop the AstraZeneca COVID vaccine in March 21, but the UK kept injecting the public, stating they were safe and effective? Why do medical professionals not ask patients for the batch numbers of COVID vaccines they had in 2021-22 to align symptoms and diagnosis to batch numbers and brands of COVID-19 vaccines? Richard then says, I have had 3 bad batches: AstraZeneca AB0012, AstraZeneca PV46684, and Moderna 3004737. I have spent £42,500 trying to get back to some level of function, but have had to fight to be listened to about these COVID-19 vaccines. If young, fit, and healthy people were dying, why did we continue with the rollout and harm those in the prime of their lives and are still struggling today?
Thank you. Andrew?
Richard, I'm very sorry again to hear about your health problems. At the time of vaccinating Jack, services in Suffolk and North East Essex Integrated Care Board were following JCVI and NHS England guidelines, including details of side effects and adverse reactions as described in the report by Fisseri Melius. The incident was escalated to NHS England as soon as the ICB became aware of it. The Suffolk and North East Essex ICB COVID-19 vaccination programme continues to follow the guidance provided by the Commissioner of this service, which is NHS England, including the most up-to-date information of adverse reactions and side effects.
Okay, thank you. I think it's also, just before I come back to you, Ruth, it is worth mentioning, I think, that the questions are numerous and the answers complex, and that Andrew, on behalf of the board, of course, we will be sharing written answers to all questions with all. So I know you said that, but worth emphasising. Ruth, back to you. I think now, are you on to the information sharing group of questions?
Yes.
Over to you.
So Charlotte Crichton details the concern expressed by experts around possible cases of vaccine-induced immune thrombocytopenia and thrombosis, or VIT, and noted the recommendation in the report around establishing an MOU to support effective sharing of information and guidance. She asks, are the board aware that the NICE rapid guidelines established on the 29th of July 2021 have since been withdrawn, and that no guidance on this condition is available now, and that NICE have said they will not be establishing further guidelines for VIT? Given that there are now no guidelines for this devastating condition, and given the investigation's recommendations, will the board consider proposing to NICE that they reinstate NG 200 rapid guidelines for VIT?
Thank you. Andrew?
So thank you. The board were not aware of the withdrawal of these guidelines. The recommendation surrounding this has been made to NHS England, and I will work with NHS England on the written answer to this question.
Okay, thank you. Ruth?
This question also from Charlotte Crichton. Given that the investigation concluded by Fisseri Melius was independent and for the purpose of learning to prevent recurrence, which public authorities have NHS Suffolk and North East Essex ICB passed on the findings and recommendations within this report to? And do the board plan to pass these findings onto the COVID-19 Public Inquiry legal team?
Thank you. Andrew?
Thank you. All stakeholders listed within the report have been sent a copy of it, and I will also send a copy of this report to the COVID-19 Public Inquiry.
Thank you. Ruth, back to you for the general questions.
Yes, this is from Gillian Humble. Why were these vaccines continued to be given when there were problems being seen with people becoming ill and dying from them? So many people could have been saved if this had happened.
Thank you. Andrew?
I'm going to answer this question and the next one with the same response.
Oh, you're going to amalgamate them. Okay, in which case, back to you for the Chris Edwards question, Ruth.
Okay, so from Chris Edwards, he's got 3 questions. What were the information provided to healthcare professionals and to potential recipients? Was this information misleading in terms of its benefit risk to young people? Were they told the product they were taking had not in fact been tested and that it could not be compared for safety, as it had been made using a different manufacturing process to the clinical trial. Was safety compromised, and what did vaccinators know about unknown risks at the time?
Andrew?
Thank you. So, like all ICBs, we were following JCVI guidance, which was based on the advice of the government's leading scientists. At the time that Jack was vaccinated, it was not recommended that patients under 30 be offered an alternative to the AstraZeneca COVID-19 vaccine.
Okay, thank you. Are there any other questions from members of the public that we haven't already received and dealt with? Are we complete, Tom? Yeah? In which case, let me just check with members of the board if there are any further questions or points before I go to Jack's family. All done? Over to you. Have you got a microphone there? Ah, yeah. We can, but yes, if you can use the microphone, it will help people who are listening in. Yeah. Thank you.
I'll do this as best as I can.
Okay.
Yeah. Jack was full of life and a beacon of light to all who knew him and loved him. In March 2021, the NHS intervened, and 4 weeks later, our son was dead. We are completely heartbroken. Every single day that has passed since Jack had his life taken from him, we have learned of more horrific tactics used by some people employed at the NHS, government, and regulations that resulted in Jack's death. We fully understand that his life was of no consequence to those portraying a position of trust, because he was our son, not theirs. No amount of farmer cash, royal titles, directives from com teams, or the mighty NHS legal empire can match the human decency shown by those who spoke up after seeing the callous disregard of life in all sectors of society during this debacle. We will never forgive those who contributed to Jack's death.
Thank you. All done. And I think on behalf of the board, we cannot imagine how you feel. And I think the sense of humility and humbleness, I think, that is around the board table is well needed and hopefully impactful. But I'm going to go to Ed. Ed, would you like to make some comments as the CEO and accountable officer?
Sure. First, I would like to offer a heartfelt and sincere condolences to yourselves, Jack's family and friends, for your devastating loss. I'd like to offer an unvarnished apology. The report's very clear that Jack's death was preventable. The CCG commissioned the report to provide an independent view and also to stimulate learning from this tragedy. And we fully accept the report and the 4 recommendations. We also note Ewan's point around kindness, or the absence of. Andrew has set out the governance to take forward the learning, and I suggest, Chair, that we bring forward updates to the board in the future so that we're publicly accountable for taking forward that learning. There's obviously a very key lesson around accurate medical data, which is at the heart of this issue. So that's what I was going to say. Thank you.
Ed, thank you very much. So if there are there any other board members who would like to comment? Otherwise, we simply have to formally process this item. So we're asked to approve the key recommendations, the 4 key recommendations which Darren kindly read out before, and one other recommendation that Andrew made, which Ed has just commented on in terms of reporting back. So let's do it formally. The key recommendations: number one, NHS England should consider developing guidance for GPs on when to move active diagnosis codes to resolved codes. Approved. Thank you. NHS England should review its current guidance to include a check for out-of-date or decommissioned telephone numbers. Approved. The Department of Health and Social Care should consider developing an MOU between national agencies, royal colleges and professional bodies to ensure that newly emerging diseases are published as widely and as quickly as possible. Approved. And then finally, in the 4 from the report, all integrated care boards, so all integrated care boards should seek to assure themselves that every practice has implemented the requirements of the data provision notice published in October 2021. Approved. Thank you. And then finally, Andrew suggested that we set up a task and finish group to reflect and learn and implement from this very sad event, and as Ed has just touched on, report back to the board on a regular basis. Andrew, when would the first report back be, do you think?
6 months. 6 months.
6 months? Yeah? Agreed? All done. Thank you very, very much. On that point, I think, therefore, this is a good moment to take a break. Let's say thank you to Jack's family for attending and for your contribution, which was heartfelt and heard and received. Thank you very much. Short break, everybody, and then we'll reconvene in 15 minutes. Thank you.
Just don't do it on your treadmill.
Okay, everybody, let's reconvene. Everybody ready? Thank you very much. And are we live streaming again at the back? We are. So welcome back to the board meeting, everybody. And thank you for your efforts thus far. One thing, just a quick bit of meeting management, that as some of you will have noticed, the refreshments have not yet arrived, but apparently they are on the way. So if we are expeditious with our timing, I'll do my best to find a 5-minute break at some point when we'll just take a short break so you can nip out and grab a coffee and we'll come back in. So let's see how we go. Okay, so let's move on to item 5, the minutes of the last meeting, 30th of July. They are there for us to check for truth and accuracy. I'm tempted, unless you want to go through them page by page, to take them on block. They are some time ago and they've been well circulated. Any issues with respect to truth and accuracy in the draft as presented? Otherwise, are we content to accept them as a true and accurate record, so resolved by the board? Lovely, agreed, thank you very much. In which case, then, let's move on to the matters arising. Now, I think, and there's a record there in front of you, of course, there's a couple of updates which I think we can do today. Ewan, item 6.2, NHP update. I realise this is very much a moving feast and has indeed moved since these papers went out, were published. So would you like to give a short update?
Yes, absolutely will. I mean, so the state of progress is that we've completed what's called an outline business case readiness document, which allows us then to proceed with the development of an outline business case. We're continuing to be funded on that basis, and you will have all heard the very encouraging news last week that the RAC hospitals are not included in the review of the new hospital programme that the new government has announced. And you know, that gives us confidence that we'll be allowed to progress such that the new hospital will be open as planned in 2030. So very encouraging news. Lots more to do.
Lots more to do. Next report, November board. Yeah, okay. Any questions on that from board members? A dynamic and moving feast. Okay, the next one I noted was item 8.8, the ECR update. I think, Peter, are you able to put some flesh on the words that are there for us?
Yes, so we were originally scheduled to go to HOSC in October. We've pushed the HOSC conversation back to January, just to give us some more time to work through with the two trusts and the local voluntary sector with regards to transport options for patients. So we'll be coming back in due course once we've progressed that further with regards to picking up on the feedback from the public consultation.
Okay, thank you. Any questions for Peter? Otherwise noted. The only other one that I spotted was the on page 142 of the pack is the MECFS long COVID work, which was reported which was accurate in July when we last debated it, that this would go to exec in September and to board in September, i.e. today. And I understand that schedule has been reworked and it's now actually going to exec in October and will come to board with a recommendation from exec in November. Do you want to add anything to that, Narinder? Do you want to press your button?
Sorry.
That's it.
Yes, we're working on finalising a new combined model of care for ME and CFS and long COVID. The paper will go to our executive committee at the ICB on the 14th of October, and then will be submitted to this board for a procurement recommendation in November.
Okay. Thank you. Tom, did I miss anything there? Complete. Any other board members noted anything that we should have updated on in the matters arising? And with respect to the matters arising themselves, are you happy that they themselves are a true and accurate record of the matters arising we should have captured. Complete. Happy to approve and endorse the responses. All done. Thank you very much. Anthony, yes, go on.
I've the questions under the matters arising.
Yeah.
Take 8.4, 8.5. My question about that provision that's just been referred to, how it was funded, that was answered. But this second part of the question, whether it was wholly to be publicly provided with no associates appointed, was not answered. Would the person, Andrew, care to complete the answer to the original question?
You want to have a go at that, Ed?
It's an NHS facility providing NHS care. I think that's the... Is that the question you're...
In terms of, we all know about PAs, about what happened last Friday with the Royal College of General Practitioners have voted that they do not wish to have PAs in general practice. It's a big issue. It's an issue about patient safety. And my question was about the qualifications of the people in this service and whether any of them are PAs, because I, for one, on behalf of the Suffolk United community and the public, I've got grave concerns about the appointment of these people.
Okay, so question on PAs, Andrew?
Just to clarify, Mr. Dooley, we're talking about the incident at West Suffolk Hospital when the baby was misdiagnosed. Is that correct?
No, that's a subsequent question. This is a question about the appointment to this new service, which is now going to be running in January. It's a question about the West Suffolk. I have responded to what you said about the fact that the report that was done by West Suffolk, bearing in mind what we've heard about the experience at West Suffolk Hospital, about it not being put in the public domain, is actually something that I think is very disturbing, something that I have referred to these, and Lisa, would you like to take up the conversations that we've had?
Okay, so correct me if I'm wrong, Mr. Dooley, thank you. I think the question is regarding ECOC and PAs and qualifications of staff therein, January onwards. It may be something you can comment on now, or do we need to pick it up more formally?
I think it'd be useful to try elsewhere clarify exactly what information I can give you that'd be helpful, Mr. Dooley, because I don't fully understand the question.
Okay.
So I'm really keen to help, but I'm not sure I can at this moment, but very keen to pick up with you elsewhere.
So let's pick up outside the meeting and then make sure the written response is in the minutes of this meeting. Got that, Tom? Yeah, okay, thank you.
Under 19.1, where I asked for the response to the change of phrase in the NHS service being free at the point of need to free at the point of service. And Ed's response was the ICB board is committed to ensuring local people have access to quality service that meet their needs, which is free at the point of use. The problem is there's a gap in time, isn't there, for the poorest people in the community, the people who can't afford to go private, between the date of their need and the date when they may get an appointment for their need to be addressed. Why don't you just come clean and say, this is all about the fact that 7 million people are on waiting lists, and this is meaning that some people can jump the queue. I've got experience with a couple of people who went to see a consultant about replacement hips. They were both told they need it, and they were told you'd have to wait 18 months to use the service. However, if they've got £16,000 that they'd like to spend, they can have it done next week. We've got a two-tier system where those who can may pay and those who can't can wait. Is this what you subscribe to as being a proper health service?
Mr. Dooley, thank you. Point well made. Ed, would you like to respond to the question? I think if I paraphrase Mr. Dooley's question, it is, do we as a board believe in a two-tier health service?
We believe in the principles of the NHS Constitution. I think the point you're making is as a national governmental issue. It's not a Suffolk and North East Essex specific issue. Of course, we want everyone to be treated in a timely way, and with our waiting lists, we're very conscious of the fact that people in deprived communities often wait longer than those in healthier communities, and that's something we're actively trying to address. But the public and private sector healthcare split is not something specific to us. I think it's a national issue.
Okay, thank you.
But that also answers the question about whether you as a board think that's an appropriate provision, and clearly you are part of a service which is about two-tier. Anyway, if I go on to 19.8 and 19.9, I actually said at the last meeting I would welcome a response to the provocation of strike action by workers at Colchester Hospital by ESNEF's proposal to outsource their jobs to maybe OAC or whatever they call themselves. And the minutes recalled this. Ed Garrett stated that the board would respond in writing.
Okay.
That hasn't happened. However, in a spirit of information and education, as somebody who used to be a teacher, I've distributed a copy of health campaigns together and keep our NHS public about this very issue, and I invite every member of the board to read it, reflect on it, and if they wish to come back to me, I'd be delighted to receive the responses.
Thank you, Mr. Dilly, and indeed we all do have a copy of that. I think as well, Howard, correct me if I'm wrong, you were intending to address at least some of these points under item 13. Do you want to deal with them now, or do you want to keep them to 13?
No, I can do it now.
Do it now?
So I
Okay.
think this is sorry.
That's all right. Over to you.
I think this is in relation to a question regarding ESNEF spending part of its budget on bringing in labour from various parts of the country. The response is the board's view is that the system's top priority remains patient care and safety. We support ESNEF's commitment to making sure everyone who uses its hospitals and full range of services continues to receive the best care that they can expect. The ICB Finance Committee reviews the overall delivery of ESNEF's financial plan, as it does for other partners within the system. And the ICB does not manage Ipswich and Colchester hospitals and does not know the details of ESNEF's contract with their cleaners and porters.
Okay, thank you.
Might I suggest that you actually find out? One of the other questions from the public is it actually in relation to that? Absolutely, yeah.
Okay, I'll come to those. I'll come to further questions at the end of the session, if I may. I'm keen to
bring in a point of information.
You may. Last one.
Yeah, I'll be quick. I've learned today that those strikers who took strike action in August and September have had 2 lots of pay deducted from their salary. That is mean, vindictive. I think that's absolutely appalling. And that's a service that you commission. You ought to be appalled too. They're some of the lowest paid workers in the health service.
Okay, point of information noted. Thank you. Okay, I'm going to move us on though at that point. So next item, Ed, over to you for the CEO's update. Thank you.
Thank you, Chair. So I'll start with some national context, then some more local updates. So the new government in place, they've invited, as we know, former Labour Health Minister, Professor Lord Darcy of Denham, I believe that's his correct title, to do a review of the health service as it currently is. He's concluded that the NHS is in a critical condition, both in terms of performance and how that performance benchmarks internationally, and in terms of many health outcomes for the population. He has highlighted various issues that have contributed to that condition, such as the effect of austerity, and particularly a 37 billion capital shortfall, which has affected the productivity of the service, the impact of the pandemic, and also the impact of the Health and Social Care Act, I think of 2011, where we saw a significant reorganisation of the management tier of the health service. He does, however, highlight that there are very strong foundations to build upon and a belief that with the right leadership, the position can be improved and recovered. With that in mind, the government have announced the construction of a 10-year health plan, which will be developed in partnership with many professionals, leaders, members of staff, and health and social care from now until probably March. 3 key principles in the plan would be around a shift from treatment to prevention, a shift from resources in the acute sector into the community sector, and a shift from analogue to digital. So those 3 elements will be absolutely central, we think, to the 10-year plan, and we will contribute to it as invited. More locally, we held our annual expo recently. I'm sure Rachel will reference it later. It was held in Colchester, appropriately, which has been named a City of Compassion, and the theme of the day was around kindness and compassion. We had 1,400 colleagues there, which was a fantastic turnout, many market stalls and an awards ceremony, which was very well received. Our keynote speaker was Sir Terry Waite, who is a local resident in our system and gave an absolutely inspirational talk. I think everyone was there, felt very privileged to listen to him and to meet him. As people know, I'm involved with a national primary care test sites programme, which is around supporting effectively the left shift of resources and promoting the sustainability of general practice, which is the foundation stone of our system. We have selected 4 primary care networks to be part of the programme in SNE, and there are 22 in total. I think that list will be published this week. We have 1 PCN that will be in Ipswich, 1 in Colchester and 2 in Tendring, and those 4 PCNs will be receiving a 10% uplift in resource, as well as participating in a quality improvement programme over the next couple of years to demonstrate, I think, what's possible in terms of general practice, and lessons will be learned and shared across the NHS more broadly, and hopefully will influence national and local policy. So it's a very exciting piece of work to be involved with. I'd like to congratulate West Suffolk Foundation Trust in the NHS Adult Inpatient Survey of 2023. They scored 8.5 out of 10, which places them 5th nationally in terms of that inpatient survey, which was a very, very impressive result. The estate's transformation, the new urgent emergency at Ipswich Hospital at Essex, the Urgent Care Committee had a tour 2 weeks ago. It's a really, really fantastic facility. It's amazing the sense of calm within there and the excitement of both the staff and the patients that we saw. Equally, the new Community Diagnostic Centre at Newmarket is now very close to opening, so we're very excited about that. And Ewan has mentioned the positive news around West Suffolk being a prioritised scheme on the new hospital programme. One of the key issues, obviously, we're very concerned with, will be discussed later in the agenda, which is around our financial performance. We're currently over plan at, I think, month 5 as a system, and therefore we'll be considering all options to bring ourselves back into balance by the end of the year. That's not uncommon in many systems now across the country. I would like to reference the launch of the Lampard Review, which we'll hear about later this morning in part 2. That has started a process of gathering evidence, and ICBs in Essex have contributed to that evidence gathering process, and all our thoughts obviously are with the families affected. And then finally, I wanted to share some good news around our diabetes care process. I think we're ranked right at the top of the country in terms of how we're performing. And Tendring PCN, which is Frida's PCN, is now ranked number 1 nationally of all the PCNs in the country, moving from 300th to the first place. So pretty impressive and great for that community. So well done, Frida and colleagues. Thank you, Will.
Thanks, Ed. Well done, Frida. So I'll come to you, Mr. Dooley, in a moment. Let me just see if there are any questions for Ed on the CEO's update from board members. No questions, so noted. Mr. Dooley, do you have a question?
Yeah, I'm surprised that Ed hasn't made a reference to the decision which I've already mentioned and you all know about the Royal College of GPs last Friday in relation to the employment of PAs. I've invited him to make a statement on that, and possibly in the context of when I raised this at a previous meeting, Frida said that whilst she had no PAs in her particular practice, she was not opposed to their employment in principle. Given the statement and the decision by the Royal College of General Practitioners, what is your response to their decision last Friday?
Okay, what I'm going to do with that one, Mr. Dooley, is because it's not a question specifically about something that Ed has raised, I'm going to take that at the end. So let's come back to that in the questions from the public at the end of the meeting. Okay, so board members receiving and noting Ed's CEO updates. Thank you very much. In which case, Maddie, I'm going to come to you for the primary medical care update. All yours.
Thank you very much, Chair. So I'm pleased to provide an update of primary care performance, transformation programmes and the collective action which is currently underway within primary medical care. And I bring this report on behalf of all three of the Alliance directors and my GP colleagues around the table may wish also to add. Thank you. So as you know, Suffolk and North East Essex has 90 general medical service contracts, and we have 25 primary care networks and 2 federations. Each alliance has its own primary care commissioning group, but we meet together on matters of strategy and policy as well, in order to ensure consistency of what we are working together to achieve. And we have been working together with our GP colleagues on the strategic plans for primary care, focused on enabling resilient and high quality services and supporting the health and wellbeing of our whole population. And there are a number of programmes of work that we are focused on to enable that, which includes access with capacity, safe working practices, resilience, workforce recruitment, retention and development, contracts, collaborative working, including with our integrated neighbourhood teams and our secondary care colleagues, and of course estates and digital that have very significant impacts on the day-to-day working of our practices and our primary care networks. We have a single assurance framework that we use in order to bring together all of the insight and intelligence that we have about practices, a way in which we can identify concerns and that we can prioritise the support that we give to practices. It's very important that we see this in the context of the demand which primary care is facing and which has continued to rise, and on the constraints which primary medical care is facing in terms of the workforce, estates, digital solutions and other constraints as we outline further below. Overall, the performance of primary medical care, the latest GP survey, which was published in June 2024, shows that 76.9, so nearly 77% of respondents were satisfied with their overall experience of using their GP practice. The national average is 73.9%. But there is, of course, diversity in that experience. There is some significant variation, some of which is caused by the factors which I described. And we work together to try and support those practices in their continuous improvement journey. In terms of the CQC, 3 of our practices are currently rated outstanding, 82 good, and 5 rated as requires improvement. And we work intensively with them. There is a new approach that's being adopted by the CQC to their inspections, and we will work with them to understand that, to support practices in understanding that as that moves forward, and of course any learning that can be taken from those inspections. I want to particularly highlight the QOF data is something that is sometimes quality and outcomes framework. We have a delay in receiving that. So I want to focus on the data which we're able to track on a month-by-month basis, which is about individuals, the priorities for us about individuals with learning disabilities receiving a health check and individuals with serious mental illness having a health check. And over the last few years, we've made very significant improvements in those numbers. But what remains important is that everybody receives a health check and that the quality of those health checks and the follow-through is supported by all partners so that we can really work to improve people's health outcomes. And there's a very important paper that Lisa will bring later in that regard. So I want to move on now briefly to transformation. It's a really important part of what we're doing is to support general practice with their transformation plans. And 42 of our practices have accessed a national improvement programme. It has a range of options. Some of this is webinar-based, and some of it is very detailed one-to-one work with practices. And the final cohort is progressing this year, after which it will be more of a localised programme, and we're working on that handover. And we're trying to understand what matters most to practices and how we can make most difference to them through this support. There's also 2 key digital-based programmes, which Peter leads on, and we work together through an MDT approach, but Peter is leading on. One of them is to enable cloud-based telephony, and this is really, really important for practices. An average 10,000 population practice may receive over 100 calls at 8 a.m. And so the capacity to manage those, part of that requires different solutions. So digital solutions can help with that. It's obviously much, much more than that, but that's one important element of it. So we're working through that, and we have tried to encourage practices to work within their PCN groupings to choose the same cloud-based telephony provider where that's appropriate. And that is part of helping to build the resilience and the capacity to support one another in unforeseen circumstances. The majority of practices within PCNs have progressed in that way. The second big development is around new digital consultation tools. So our practices do have digital consultation tools, and some of them meet their needs really well, and they have been using them very holistically to provide care over a long period of time. Other tools haven't worked as well for practices, and so we've been taking this opportunity to ask the practices if they would like to look at demonstrations to understand from a patient perspective and an operational perspective what works for their community and their teams. And that work is now complete, and we're in the process of procuring a small number of digital tools. Obviously, all of that will require support. These are big change processes, so they will require support for patients, for the public to understand change, and of course, fundamentally for staff. And the Training Hub has been supporting that transition programme for a number of practices. There are also a number of ways in which we're trying to improve access for patients in the programmes such as the NHS app and offering prospective records access for patients. And we are continuing to work on that. So we have, again, it's not a uniform situation. So we're working with practices and with patients and the public in those areas to try and continue to improve access in that way. Pharmacy First is also offering a number of new ways in which patients can access services in a managed way. And we have some very positive take-up of those services. But once again, there's more that we need to do to help people understand the conditions for which a pharmacy can support and meet their needs, and the ways in which practices can also support direction to patients to those services, and that can be safely accessed and recorded. I've mentioned estates a few times, and estates really are a critical part of the support that we need to bring to practices to enable greater capacity. We have not got a very large access to capital for primary care at this time. Nonetheless, we have worked to understand need. We have worked to try and prioritise based on environmental challenges. So we have some very serious environmental constraints, flooding risks, not only of the buildings, but of access for our practices. And also we have looked at what the constraints are relative to the national model for space. And we are trying to prioritise on that basis and to progress all the opportunities that we can for access to Section 106 and community infrastructure levy funds in partnership with our local authority colleagues. And that's a really productive and positive partnership. But I think the estates team are working in the very best possible way they can with the constraints that we have. And we need to be very ready for opportunities that we hope will be forthcoming in the future for larger scale capital. Just wanted to touch briefly on primary care networks and on workforce, and Amanda or Dave might want to say further. But our practices and PCNs are continuing to try to take every opportunity to recruit the new roles that are available to them through the R's scheme. And most recently, there has been an announcement that it will be possible to recruit GPs through that scheme as well. And that was announced in August, and we wait for the detail of that. There is a very positive number of GPs currently in training across Suffolk and North East Essex. And the expansion of that programme has been really very, very positive. Estates, again, remain critical to enabling that to be sustained and to continue to grow. Within the paper, I've also made reference to the pilots, but I think Ed's covered that wholly, so I won't say further about that, but it's a very positive opportunity, I think, for us to work in partnership as ICBs across the country, with the 7 across the country, with our local PCNs to really understand demand and capacity and understand what we can do more or differently to support them and what investment can help them to bridge that gap and to continue to build the partnerships between practices within PCNs and with their wider community and other colleagues. Last but not least, it's very important that I mention the collective action which is currently underway within primary care. And there are a set of areas which practices are being asked to consider in response to the uplift that was originally offered and to the subsequent uplift, and which is disputed. And so there was a vote, as you will all be aware, and a rejection of that contract and offer. So I list in the paper the areas which practices may choose in order to take action and to manage their workload. So the assurance that I think is appropriate to give to the board is the way in which we are liaising with our LMCs in response to that, and to work with partners to ensure that there is an appropriate response. So we're having weekly meetings with the LMCs and separately with system partners to develop, enact, monitor and evaluate our operational responses. And of course, we are reporting to NHS England. I'll leave it there. I'm of course happy to take any questions. The only thing that I should say perhaps, Chair, is that if there were questions specific to any individual practices, then I would probably wish to take those and reply in written form in order to ensure that they are accurate. Thank you.
Yeah, fair enough, Maddie. Thank you very much. So, colleagues, Elaine.
Yes, thanks very much, Maddie, for going through the report. Obviously, a lot of things being done to improve services, which is really good to hear. There was 2 questions I'd like to ask, if I may. The first is regarding people having access to a GP, because one of the things I was looking at the report was if there was any information on how long people wait to see a GP, and if that's something that is known or can be measured, so that, again, there can be comparison and improvements made in those access times or waiting times. And then my second question was around transformation. We talked about the digital transformation, which is great to see. But in terms of workforce, I know you touched on that, but I wondered if there's any more to say around using other kinds of professionals. Like, for example, my local GP surgery uses nurse practitioner, which has really helped to remove some of the load for the GPs. If there's intention to do potentially more of that using nurse practitioners or other allied health professionals to augment the GP service, so it'd be helpful to just understand either of those things.
Thanks, Elaine. Maddie?
Thank you for those 2 questions. So at the moment in Suffolk and North East Essex, about 83.5% of patients are seen within 2 weeks, and over half are seen within 48 hours. But many more than that will be triaged. So when people call or access their practice via an online consultation, then their needs will be reviewed and understood, and if appropriate, then they will have a call back or an appointment with a GP or other health professional within the 48 hours, or an appointment may be made within 2 weeks generally. So that's generally where we are today. And that compares quite well with the national position. So there are some practices where all demand will be met within a day, and colleagues Dave may wish to explain a little bit about how the model works in the practice that he works in, for example. So there are a range of different models, and they will be designed with the community in mind, and obviously with understanding of how the teams work locally. So we continue to monitor over time the access that patients have. In terms of the teams, our teams within primary medical care are multidisciplinary teams of GPs, of nurses, of social prescribers, of pharmacists, of physicians associates, of link workers, of care coordinators. So it is a diverse team that is developed, and it will also be different within each practice, again, that's been identified to meet the needs of their population. And the teams have support of the training hub, the Suffolk and North East Essex training hub. So there are leads for each individual profession, and there are training programs which those professionals have access to through the training hub. So we're trying to support the individual professionals, and we are trying to support the teams within practices. And as many of you know, the other thing that we work to secure and to support is the clinical knowledge of teams through the training events that are held within each alliance area. I hope that goes some way to answer the questions. Thank you.
Okay, thank you, Maddie. Dave, you were invited possibly by Maddie to see if you had any comments. Do you have anything you'd like to add?
I don't think I've got anything to add, to be honest. I think there's...
Okay.
Could I add something if David
Yes,
hasn't?
of course.
Sorry, Dave. Is that
Yeah,
okay?
go on, Frida.
So just to say that workforce-wise, just in answer to your question of workforce, that's critical in general practice, obviously. And it has got better since the advent of PCNs, because we've been allowed to, via the PCN, employ what's known as R's roles, which has expanded our workforce and allowed us to delegate via triage more effectively, so GPs are less likely to have to deal with, like, for instance, a physio problem. I've got a physio, I can now direct the patient without having to intervene at all. So that does save my workload, and also is it more appropriate for the patient. So the R's roles have helped. And as Maddie said, that the GPs and AMPs are now going to be allowed to be appointed via the R's system or process. These will be junior GPs, newly qualified. I think it's very important to make that point, because there is a problem in nationally that whilst we have an issue with GP not being enough GPs, there's also GPs that are unemployed, and it seems like a bit of an oxymoron there, but it is the case. So in order to level that, I suppose that they've allowed for the R's roles to take on GPs newly trained. I have a slight issue with that in terms of potentially undermining the role of partnership, but that's that we can take that outside. But in terms of just going back to the multidisciplinary team, it does depend on the clinical governance within each PCN or practice to allow for that to work effectively. Now, most of the R's are independent practitioners like physiotherapists, and AMPs can function very much without the need for GP overview necessarily. But going back to the point of PAs, the issue is very much the governance of that and whether we are the appropriate people to govern that kind of clinician, if you like, and whether those steps have been taken within general practice as safeguards. So that's where the current argument and debate is about PAs. But overall, as long as we have those R's roles are actually helping, I'm sure David would agree, in terms of the multidisciplinary approach and workforce.
Okay, Frida, thank you. Lisa, is your point, is it on this subject? It's not. Okay, in which case I'm going to go Andrew, Fanwell, and then Lisa. So, Andrew?
I'll be brief. The evidence is overwhelming that strong primary care is fundamental to good health outcomes in a healthcare system. And whilst I'm frequently reminded of some exceptional quality of GPs working in our system, it's undoubtedly the case, Maddie, that the work you and your team do to make that service better and to enhance it and support it is one of the reasons why it's so successful in Suffolk and North East Essex and why we produce some of the outcomes that we do. So I just wanted to thank you for what is often unseen. I see it day to day, but often not seen. But I think your report details very well the considerable effort that goes into supporting primary care, which we need.
Okay, thank you. Thank you. Noted. Thank you. Fanwell?
Thank you, Chair. Maddie, you mentioned estates a few times, and it is a real challenge. I mean, obviously, noting the lack of capital funding nationally, and also some of the reported financial pressures on our local authority. I feel that the storm is probably approaching much quicker than some of these initiatives you mentioned that our estates team are undertaking. Do we feel that we have captured this risk appropriately across the whole system, including our BAF? It's just sort of noting that there is a big challenge. Are we alive to that as a system?
Maddie, do you want to comment on that?
Thank you, Fanwell. I think that that's a really good question, and perhaps Amanda and I could take that together and consider whether we need to escalate that further, Fanwell.
Okay, so feedback after you deal with it outside the meeting and feedback.
Can I just add a quick comment to Fanwell's question and what Maddie said as well? I think we should take it further forward, and I think we have opportunity to revisit risk number 10 within our board assurance framework and make sure that we have got the necessary action, mitigation, and everything else that we need to be taking to address that wider estate issue. Thank you.
Thanks, Amanda. And Ed, is it on this subject?
It is, yeah.
Over to you.
It's just a very practical one. I mean, our ICB, in common with most ICBs, has void estate. I'm not sure we've ever really looked at it in terms of how those voids could be occupied with primary care services. I know we're thinking about that in one community, but that could be an easier way forward than some of the other options that we have in general practice.
Should we note that and include it in your outside the meeting and feedback? Wonderful. Thank you very much. Lisa?
Thank you. I just wanted to take the opportunity to give a reflection. I visited Summit in Clacton and the SOS bus recently. For those of you that don't know, Summit is an advocacy organisation that supports people with serious mental illness, people with a learning disability, homeless people. And We hear a lot from our public around the difficulty in contacting surgeries at 8 a.m, that kind of famous 8 a.m. call. But Summit and the outreach workers that I talked to were reflecting the very specific difficulties that the people that they advocate for experience. So if you have serious mental illness, making that 8 a.m. call is incredibly challenging. And if you are homeless, having a phone with enough credit on to keep on the line for 40, 50 minutes, if you have a phone that has charge on it. And it's not really a question, but it is, how do we make sure that adjustments, the reasonable adjustments, are made so that people who need those adjustments can access GP surgeries with the same consistency that people that maybe don't need those adjustments?
Good points, Lisa. Maddie?
Thank you, Lisa. It's a really important question. So I guess the tenet of a great deal of what we're trying to do is to reduce the 8 a.m. Rush, which is really shorthand, I think, for so much more, and to try and support that to be a more even approach for patients and for the teams throughout the day and the working week. In terms of homeless individuals and people that you were talking about in terms of with serious mental ill health. So we do have a number of really important people who work as advocates and supports. So in Suffolk, the Marginalised Vulnerable Adult Service supports individuals who are homeless, in particular, through an initial journey of health assessment and support and introduction to general practice. So there is a service there to support people. I think it's always important that we ask ourselves, is there more that we could do and more help that we could offer? And for individuals with serious mental ill health, there are also within NSFT, and I'm sure EPUT too, colleagues who work with individuals who look at their physical health and well-being as well. And our social prescribing teams within practices or across the community should be able to support people as well. So I think you raised an important question, and we probably need to reflect about whether we have got everything as joined up as we need to. There is definitely support there. We need to make sure that people are able to access it in the way that works for them. Thank you.
Thank you, Maddie. So,
Can I just comment?
of course you can, Frida. Yes, come on.
Sorry, just going back to Lisa's point, I think it's also really important that, well, as Maddie said, access is equal to all. And I think in some ways the digital platforms have kind of pushed GPs into one way of thinking. And I think we need to make sure that all practice still open their doors and their telephones and to walk-ins. I think that's a really important thing that we certainly do in our practice, is that, you know, we do allow for that access still to continue. And I do know that some GP practices have kind of totally focused on the platform, and that needs to be kind of just addressed a little bit to open up that point.
Yeah.
Really.
Noted, and I saw a lot of supportive nods around the table to those points. So thank you, colleagues. So as a board, we've noted an additional piece of work to happen outside the meeting and report back to the board. So with those comments and points, are we happy to note and receive the update on primary medical care? All done. Thank you very much. Now, item 9 is the leader annual report. Now, Lisa, we're running a little bit behind, and if we're going to get a few minutes to give people a break to get a coffee mid-meeting, if you can do this in 10 minutes, that would be a great advantage all round. So over to you.
Thank you, Chair. So I will certainly do this in 10 minutes. I'm not going to go through the report, because every year I bring the leader annual report here and go through the data and go through the themes. And what I wanted to do this time was to bring you 2 patient stories. So I have the patient stories of Neil and Alan, who were 2 patients that we reviewed as part of the leader process, who very sadly died within SNE, and I'm incredibly grateful to the families for allowing me to share their stories with you at board, and for supplying photos that show how wonderful Neil and Alan are. So I'm just going to share those, and then I would like to, I mean, you can obviously ask me questions about the technical aspects of the report, but I would like to ask you as leaders within the system how you champion and advocate for people with learning disabilities and autistic people within your organisations and services, because it's not something that a corporate LD team can do. It needs all of us to make reasonable adjustments and to make sure that the people accessing our services are treated equitably and consistently. So the data that you will see on the first page just runs through why we have the leader programme. We received 106 notifications in 2023-24, which was significantly more. We received 69 in 22-23. Interestingly, we now also extend that to autistic people, but we only received one notification of death. So that's a piece of work that we need to continue working with our providers, our GPs, our medical examiners and coroners to make sure that we're receiving the notifications, because only by reviewing the deaths and looking at the themes and trends across the system can we extract the learning. So the median age of death for all people without a learning disability across SNE was 82, but for people with a learning disability is 62 years old. It was 61 in 22-23, and you will see if you look at the full report, actually the median age has dropped in Suffolk, but has improved in North East Essex from 56 to 62. The percentage of people with a learning disability dying in hospital decreased, so 50% of those that we reviewed died in a hospital setting, compared to 65.2%, which I would assume is a good thing. Hopefully it means that people are receiving more individualised end-of-life planning in their homes and are being supported to die in their place of choice. We know that respiratory conditions are by far the leading primary cause of death. And reflecting back on what Maddie said, a high number of people that we reviewed had received an annual health check within the last year of life. However, only 39% of them had a health action plan completed. And we say it every year, we say it all the time, an annual health check is brilliant, but if you haven't got the plan that oversees the delivery of the health, it is not a completed process. You have to have the health action plan. So I just wanted to share Neil's story with you. So this is Neil on his boating holiday. Neil was a talented man, was artistic and musical, and loved all music and was supported to mix his own music. Neil was afraid of hospital. He had a traumatic experience, having stitches out as a young boy, which may have been the start of Neil's fear of hospital. And Neil was 59 years old when he died in one of our hospitals. He had, as a number of people with learning disabilities do, he had incredibly complex health needs that he had great support for. The GP and his consultants across cardiology, oncology, neurology gave him great support and good support with those. However, his physical health, it was recognised with his family, was poor. So he had an end-of-life plan that would allow him to die at home when the time came, in his own bed, in familiar surroundings with his family, people who knew and loved him. One of his conditions meant that he had swallowing problems, and in June he saw a learning disability speech and language therapist for an assessment. He had a really great assessment and recommendations with easy read instructions for him and his support workers. In January 23, he had a thorough annual health check. In May 23, he was admitted to hospital with chest pain, and during that admission, he was left to eat and drink without supervision. His sister made a complaint to the hospital. Alerts were put on the hospital system, as well as his hospital passport. SALT guidelines, staff training needs were identified. However, a week later, he was readmitted to hospital. The nursing assessment dietitian referral stated that he was independent in eating, which was not correct. And the hospital investigation into his death presumed he'd been left unattended whilst eating and drinking and aspirated over the weekend. And sadly, Neil died of aspiration pneumonia at 59 years old. I'm going to share Alan's story now. So Alan was the oldest of 5 siblings. What a lovely photo of Alan. He was born in 1956 in London and was badly bullied at his residential school and would run away. His family moved with Alan to Suffolk in the 1970s, and he went to an adult training centre and was an army cadet. He attended an art group until COVID, but carried on producing art at home. Alan died when he was 66 years old, and when we've looked at the range of deaths within the leader reviews, that 45 to 65-year-old age range is the most frequent age of death. He presented as able, but had little insight into his own health needs. He was a man with complex health needs again, who was reluctant to tell people when he was unwell or in pain. However, the condition that had the greatest impact on his life was cellulitis in his leg, which was first noted in 2017, 5 years before he died. When his cellulitis became chronic, he would frequently tell people to cut his leg off. He needed frequent dressing changes, but the leader review found that reasonable adjustments were not made to allow him to access the frequency of treatment with the support he needed, because the GP surgery would not make appointments for him in advance. And his home, his supported living home, couldn't change their rota at short notice to accompany him to have his dressing changes. At one stage, when he was really poorly, he received consistent treatment for 3 weeks from the district nurses, which showed a real improvement in his legs, and as such demonstrated the possibility of full recovery if he had had reasonable adjustments made in his GP surgery. As his cellulitis worsened, he was advised by his GP to be admitted to hospital for IV antibiotics, but he declined. There was a presumption of capacity by the GP. The leader review found that if a mental capacity assessment had been completed, it would have been evident that Alan was not able to make an informed decision about that health need. And on the 16th of November 22, Alan died of multi-organ failure from sepsis. So I'm just going to finish with this slide, really, which brings the case studies, it brings the recommendations and the themes that we find from the case studies. So no advanced care planning, end-of-life plan in place, a lack of reasonable adjustments. Of course, there will be some people that have amazing reasonable adjustments made, but the deaths that we review frequently demonstrate lack of reasonable adjustments, lack of people understanding how to care for people with learning disabilities and how to make reasonable adjustments, not listening to families and carers, poor communication with families and carers, poor discharge planning, and I'll let you read the rest. But thank you, Chair. That was all I was going to present.
Lisa, thank you very much. And board members will note a common thread, of course, from some of the issues we've already discussed this morning. And Lisa, your request for, obviously, any questions, of course, but your request is that we as a board and us as individuals commit to making appropriate adjustments.
Yes, so each NHS organisation will be benchmarking themselves against the National Learning Disability Standards, And I would request that each organisation considers how they have oversight of the care that people with learning disabilities and autistic people receive in their organisations. How do you know? Often people with learning disabilities and autistic patients are not your frequent complainers. They won't show up in your complaints data. You need to go out and listen to them and make sure that you hear their voices. Have you got experts with experience that work with you in your organisations, and how do you champion and advocate the needs of people with learning disabilities? Thank you.
Thank you, Lisa. And actually, I'd quite like to hear from anybody who won't make that commitment. So otherwise, we're going to take it that we definitely are individually and collectively. I've got Janet, Fanuel, and then Kath, and Moira. So let's do it in that order. Janet?
Thank you, Chair. Lisa, thank you very much for sharing the report and the stories. They are incredibly powerful, and they give us some real food for thought about what we do. I'm drawn to the Oliver McGowan training because I'm privileged enough to have done that, and I know in the ICB we've got a really high take-up rate. I just wondered how that was throughout our providers. And then picking up your point, do we need to have a dashboard that we can get some assurance from around all of the partners and the contribution?
Yeah, Lisa?
Yes, so we formed a collaborative, and the ICB is offering training to all providers that would like to be part of that collaborative. So we are providing the Oliver McGowan training. I would say it's inconsistent across providers. I don't particularly want to name and shame providers, but we have some providers who have done everything they can to make sure that they are attending, and we have some that have decided not to be part of the collaborative. So there's still work to be done. Thank you.
So work in progress, but as a board, are we asking for delivery on that work? I think that's the message. Yeah. Okay. Thank you, Fanuel.
Thank you, Lisa. Just wanted to bring to your attention a number of resources that were reported recently. We might already be sort of looking at them, but the Disability Advice and Welfare Network launched a passport for autistic people to help them advocate in different settings, like health settings, police, and other places. And it's a free resource that is available, and it might be something that we want to publicize. But also locally, the Suffolk Law Centre has done a project with young people, 16 to 25 autistic young people, and again, sort of similarly to help them understand their rights and to sort of help them to advocate for themselves. So these might be reports that we want to tap into.
Yeah, noted. Thank you. Kath?
Thank you. Thank you, Lisa. It was a really tough report, but the case studies really brought it to life. I've got 3 points I wanted to raise. Firstly, NSFT is fully committed to Oliver McGowan training, and we did a mandatory training review in the spring and early summer, and we have introduced that as mandatory within NSFT. So I'm pleased to share that with the board. The second thing, in the grey box top right on the screen, it makes reference to the themes relating to learning disability as a cause of death. There is new guidance for how death certificates are written, and the guidance is pretty clear now, saying that learning disability should not be used as a cause of death. So my question is, firstly, do colleagues all know that around our system? But equally, will it make it more difficult for us to identify people with a learning disability who have died if that is not on their cause of death? And then my third comment related to equity. So earlier on in a different conversation, we talked about equality of access, and I would argue, particularly people with learning disabilities, we shouldn't be looking for equality of access to services. We need to be focusing on equity, and that means we need to do more and differently for people who can't access services in the typical way. So I think we all need to explore how are we essentially, not purposefully, but discriminating against people with a learning disability or autistic people who are not able to access services. And Alan's case, I think, is a classic example where equity has not been
a principle that he was able to benefit from when he was alive. Thank you.
Thank you, Kath. Do you want to comment on the death certificate, or do you want to think about that and feed back on it, Lisa?
I think I might have to liaise with my esteemed
Yeah,
colleague.
yeah, it's a good point, but
Thank
but
you,
there's a lot
yes.
to that, isn't
Yeah.
there?
I mean, obviously, learning disabilities should never be on the cause of death, the same as in a DNA CPR form, but we do still see them. Yeah, thank you.
Yeah. Okay, Moira.
Thank you. I was going to ask about Oliver McGowan training, but I think that's been covered. So the comment I want to make where I think these issues really were brought to life for me was talking to a man with learning disabilities called Richard, who said he was sitting in an outpatient clinic and he observed a prisoner coming in. And he said the adjustments that were made for that prisoner were not reflected in the support that he had. And he said, if the NHS can make those adjustments for prisoners, why can't they do that for me? And these are really fundamental issues. So I think the point about reasonable adjustment, why Oliver McGowan training was brought in, was so that we really appreciate and understand the importance of equity of access. These are quite fundamental things, basic rights to access care.
Back to the Kath's equity point, isn't it? Yeah. Yeah. No, thank you for that, Moira. Good point, well made. Andrew?
I've got a few things to say now, actually. Sorry, I've accumulated and they don't particularly join together apart from the fact they're all about this paper. So reasonable adjustments, I think, is very interesting. It's become quite tokenised, hasn't it, as a phrase? In fact, it's become so tokenised, we've capitalised both words, and now it's almost a noun in itself rather than something you're describing. And they're often neither reasonable nor adjustment. They're the minimum we can do to tick a box. So I think we should reflect on the fact that reasonable adjustments actually really mean something. We don't do root cause analyses anymore. They're felt to be a bit reductive. It's not something we use in patient safety. But if we were to do a root cause analysis on all of those things, on the themes leader reviews, one of the root causes might be a lack of curiosity. And this, in my view, this is something I've seen again and again and again in my clinical practice, is that we fail patients with learning disability because we're not curious about them and their lives and their conditions and everything about them. So the thing to encourage all of you to take back to your organisations is to really, really drive that curiosity. It's something that all clinicians start with, and somewhere along the way we lose it, and we've got to bring people back towards that. And those of us that are clinical leaders do that all the time, but we need to do it more. The thing about medical death certificates, I'll come in on as well. Yes, it may become, we may not be able to identify patients with a learning disability that have died from the death certificate if we remove it from it, but it was never a very reliable way of identifying them anyway, because it was a bit hit and miss, wasn't it? Medical examiners now review every single death certificate with the certifying doctor to make sure that the cause of death is correct, is appropriate, and the appropriate supporting factors in death are also recognised. So we should not ever see learning disability on a death certificate now as a cause of death. However, there's a really interesting point about how we identify patients that have died with a learning disability, so we can make sure we're doing the right job and we're reviewing the deaths when we should be doing. I don't have an immediate answer to that, but I'm going to talk to the medical examiners and just work out if there's a way, and maybe the coroner as well, if there's a way we can do that.
Good point. Thank you. Thanks for making that point, Andrew. Let me go to, I think, Ewan, and then we'll try and wrap up on this one. Ewan?
Thank you, Will. Lisa, you asked at the start, some of the things that we're doing, some of the ways we're listening to people with learning disabilities and their family, and about assurance. So I think just to highlight, we've recently established a joint service users meeting for people and their carers and relatives to hear from directly about their experiences. We have a sort of mechanism of trying to identify patients within the hospital on a daily basis who have learning difficulties, so that we can try and establish the reasonable adjustments that need to be made, and very ably supported by our learning disability specialist nurse. On the assurance side, we take that through our assurance committees, and of course you carried out an assurance visit recently for the organisation. And then just the final point, we're trying to identify all incidents that involve patients with learning disabilities through our PSERF process on a daily basis. That's just a sort of snapshot of some of the things that we're doing.
Yeah, useful update. Okay, thank you, Ewan, for that. Let me make a suggestion, colleagues. Frida, last one, Frida, and then
Sorry,
we'll...
last one, Lisa, just comes to mind about McGowan training. I have done it luckily, but many of my colleagues haven't. And I did ask through the senior partner group about how that was going. And it's quite poor uptake in primary care and access to it. So just if you and I could touch base maybe outside the meeting at some stage, just to talk about McGowan training within primary care, that'd be really good.
Great, thanks, Frida. So, Ed, Lisa, well, Andrew as well, I'm just conscious of how important this item is and how it is sort of a glue that's holding together a lot of the threads of today's meeting as well in the wider context. If we wait for 12 months for the next annual report, it rather seems a long way away. I'm just conscious as well, we've called for a lot of actions and a lot of checking, and we need some further data. How about we have a mid-year, a 6-month report and update? Would that be, are you happy with that? And board members comfortable with that approach? So then we can get an update on all those actions that we've called for. Andrew?
We're in the process at the moment of reviewing the data we look at in Quality Committee, which is the subcommittee of this board, and a suggestion would also be to take something from Leader as a metric we look at regularly every time Quality Committee meets to make sure we're on track.
Standing item on the agenda. Should we make or a regular item?
I'm trying not to say the word dashboard because it's very left hemisphere, but we're looking at our dashboard.
Yeah.
I want to make sure there's something about Leader data that flows through the dashboard.
So let's delegate that to Quality Committee. Yeah? Agreed? Happy? Well, happy's not the right word, is it? But you know what I mean. Content? Agreed? Good. Okay, thanks. Now, colleagues. Okay, so we didn't achieve the 10-minute target there, Lisa, I'm afraid, but I think that's a reflection of how important that subject is. So thank you for your patience so far. I'm going to call a 10-minute break so that we can go and get a break, but also make the most of the refreshments that I think you need for what will be a very rapid last hour of this meeting. I'm hoping that a number of the agenda items that we've got to come, we might, with board agreement, take them as read. So I'm hoping that we'll catch up on the time available. But 10-minute break. I've got 11:32, so we'll recommence at 11:42. Okay? Thank you very much, everybody. Okay, everybody, are we ready to restart? And colleagues, are we back online? We're back online. So we are now in public. Right, let's get ready and go. Okay, thank you for being so prompt, and I hope that break was useful. We've got now a rapid hour in front of us. And I'm going to go to Kath to kick us off. Kath, your item, please.
Thank you so much. I just wondered if somebody could move the slides. There we are. Thank you so much. So this slide deck will be available, and Tom, you'll be able to distribute this after the meeting. So I wasn't planning to go through every slide. This is just an update from when I presented where we were at back in March, I believe. Are you controlling the slides at the back? Because my clicker doesn't work. There we are. Lovely. Thank you. So just to say that since we met in March, the Trust has launched its new vision, Safer, Kind and Better, and that's about improving together. Our new strategy was completed in May and presented to our board in public in July. And we also have our new Trust values, which is that we talk, and that is we're a team, we're accountable, we learn and improve, and we are kind. Beneath our Trust strategy, we have 9 enabling strategies, 5 of which were approved or ratified at board in July, and the final 4 are being ratified this week in our board in public. And they all underpin our priorities around improving health, improving care, improving culture, and improving value. So we have our 12 large-scale change programmes, as you can see, within those strategic priorities. And within the slide deck, what you'll see is an update in terms of our position regarding delivery against all of those large-scale change programmes. You'll see where they are complete, where they are planned to complete and are on track, but also where there may be delays in relation to delivery, as you can see on this slide, particularly within the completion of must-do and should-do activities, and they're due to conclude by the end of this month. And what you'll see again in terms of areas of delayed is our efficiency, value and improvement plan. And again, that is due to conclude this month, but it's taken us longer to progress with that programme. I'll just pick up a few points within this. Clearly, I won't go through all of this in detail, but in terms of within improving health and our learning from deaths is one of our strategic priorities, and we've already previously been clear about those priorities within this is about collecting, analysing and reporting on deaths. And we know now that we have every Trust board held in public a mortality review document reporting the most recent reportable deaths in terms of the analytics behind that. And of course, in July, we published the learning from deaths analysis from people who died between 2019 and 2023. It's about also ensuring learning, which influence clinical practice. And of course, it's working with our service users, carers and bereaved families. And we have our Learning from Deaths Action Plan Management Group. And we will be in September approving our bereavement standard operating procedure, which has been co-developed with service users, carers and bereaved families. As part of improving care, we committed to a reorganisation within the trusts, and we had at one point, I believe, 11 care groups. We are down to 8 currently, and we are about to launch a new structure within the organisation where we will have 5 locality teams. And from a Suffolk perspective, we have West Suffolk, we have East Suffolk, and for the Waveney element, it forms part of Great Yarmouth and Waveney. And of course, then in Norfolk, remainder of that is West Norfolk and Central Norfolk. We've broken that down into 3 phases. We haven't just focused on the most senior colleagues within the organisation. Actually, we are going down to leadership roles, down to A to A within the trust, and we have a plan to introduce far more clinical leaders within our organisation, overseeing the delivery of clinical services. We have introduced Listening into Action. This is a programme that Caroline Donovan, our CEO, has used repeatedly in previous organisations, and it's really been embraced. This is about how we listen to colleagues across the organisation and empower colleagues to be the driving force of change. And it's a methodology to do that. And it, as I say, it's been really engaged. And you can see on the slide above, it incorporates the opportunity to identify quick wins, but also bigger programmes of improvement that need to be put in place through a process called the development of pioneer teams. So we have 27 pioneer teams working at the moment. We'll have a Pass It On event in November, and then our Wave 2 pioneer teams will launch in January. A big area of improving culture within the trust is about being open, and we are doing a lot of work in terms of working with our service users, carers, families, and we are developing a service user and carer council, a trust-wide service user and carer council. And once that's established, we've gone through a recruitment process, and we have appointed two colleagues, two service users and representatives from families and carers to join the council. And the chair of that council, who will be voted for by the council themselves, will have a seat at the table at our trust board from November onwards. And then as we establish our new localities, those 5 geographical localities, we will also set up service user and carer councils in each of those localities, and the chair of those locality councils will then also have a seat on the trust-wide service user and carer council. Improving value, so real challenge, as it is for every NHS organisation. We are, in order to achieve a break-even position, we need an efficiency target of 5%, which equates to £17.4 million. And we are still in the planning phase for some of that. But it's really important, this is not a cost-saving programme, this is efficiency, value and improvement. And some of our EVI programmes don't necessarily save money. They are very much about how we use our resources much more wisely. So if you look at to the right of this slide, making improvements that result in clinical efficiency and effectiveness, but also corporate efficiency and effectiveness, and how we can do things better and make use of the NSFT pound. And then finally, just to share the recovery support programme. So we are currently rated as NOF 4, which is the lowest of the scale 1 to 4. We are on track to complete the exit for NOF 4 by the end of 2024. So we will have submitted all of our evidence for the regional group to sign off in January. So subject to that process, we are on track with our RSP trajectory to exit from NOF 4 to NOF 3 in Q4. And within the slides, what you'll see is all of the exit criteria set out in terms of delivery, planned delivery. And the only element you'll see is rated as red isn't actually one of our NOF 4 exit criteria, but we feel it's really important to factor in financial delivery. So we added this in, and as I've said, EVI programme is behind trajectory, but we are working to achieve that break even by the end of the financial year. So I'm happy to take any questions or comments. Thank you.
Thank you. And Tom, you're going to circulate those slides. Thank you. Perhaps I could suggest to board members as well that if once you've had time to digest the slides, if you've got any further questions, if you could route them through Tom, then over to Kath, and we'll include a written question and comment in the post-meeting record. And also, 6 months' time, NOF 4 exiting and so on is really pertinent. Should we be scheduling? Could we schedule another update in 6 months' time? Yeah. Okay, that's good. So with those comments, any questions, Ed?
Thanks, Kath, for it, and lots of really good positives in there. On the structure of the organisation, so we've got the kind of 3 localities in Norfolk, which I'm really pleased to see, and the 2 in Suffolk. So my kind of question was to Peter and Maddie, really, is the 2 localities in Suffolk obviously map to our alliances in Suffolk. So is there a different, better conversation now we can have at a locality level, alliance level, as a result of that?
Peter?
Yeah, we'd really welcome that. I think there's 2 development areas I know working with primary care that we'd like to work with you on, and that's the dementia diagnosis memory assessment clinic capacity, which is we want to try to improve and increase with you, and also the adult community mental health teams and those relationships with general practice. I know that's a sort of a tricky issue we've been working with, but it's such an important one at a local level, and obviously we can bring all of our neighbourhood teams have a voluntary sector component to them, and mental health is nearly always top of the list of areas where local charities are wanting to work with us and work with NSFT more closely. So I think all those 3 topics would be really successful, I think, for us to come together.
Should we take that as agreed, Kath?
Yeah, absolutely. I'll just add that part of the reason for the new groupings to be co-terminus with the alliances in Suffolk is for exactly that reason. We've been too inward facing as an organisation, and actually part of the new leadership responsibilities in the new structure is to be far more outward facing, and that link is welcome. Thank you.
Okay, noted, agreed. Thank you very much. Any other points? Otherwise, with those actions that I summarised with earlier, we'll go with that. Agreed. Thank you very much. Now, the next 2 items, 11 and 12, the Anchors Programme Board update and the VCFSE Sector Resilience update. Susanna's obviously given apologies today, but Rachel, you're going to lead on both, and you have a plan, I believe.
Yeah, thank you. And hi, I'm Rachel Jennings. I'm the Communities Lead and I work for the Integrated Care Partnership. So because we've got 2 papers and due to time, I'm going to go quite quickly through the Anchors paper so that we've got more time for the voluntary sector review, if that's okay. So in terms of the first paper, which is around the Anchors Programme Board, there are slides, and it would be great if everyone gets a chance to look at them after the meeting. But the first few slides are really summarising about what the Anchors Programme Board is and the membership. And the key points from this is it's about how we convene our NHS providers. It's very much about how we provide that collective accountability for those organisations and think about how we can look at joint priorities that can help progress the work of Anchors within those organisations. When we go through the slides, we get to sort of slide 5 and 6. This is when we're looking at our Anchors dashboards. So this is a big piece of work which we did last year. My colleague Liesel very much helped to establish the dashboards. And basically, we're really clear on what they were and what they weren't. And it was really helpful that ESNEFT had been piloting the first versions of the dashboards for the past year. And the dashboards are an opportunity to reflect on the different Anchors pillars, so whether that's around workforce, whether it's around procurement, estates, sustainability, or communities, and really think about what activities are happening within those organisations and use the templates, dashboards as a reporting method to be able to have these conversations at board level, to think about within our organisation, what are our priorities, what are we doing well, and where do we need to focus our efforts. It's quite a big piece of work doing the dashboard, so it's been very much an iterative process, and over time what we've agreed is that actually, due to the breadth of Anchors' work, looking at 1 or 2 pillars at a time rather than doing the whole dashboard was the most beneficial way to do that. So the most recent dashboard, which we did at the start of the year, was around workforce. And included within the papers is an impact report which was shared, so it'd be great if people have the opportunity to look at that. And what that did was enabled us to bring together all of that insight which we had from the dashboards. And I think overall we had something like 80 examples of activity that was taking place across the different providers. And one of the things we do is we link in with our other existing committees that take place within the ICB. So with the workforce, I was able to speak to Amanda and say, well, how do we add value to all of this insight and what can we do with it? So Amanda said it'd be great if we can bring in some of our other partners as well, our key stakeholders. So that's how the impact report evolved. And actually what we've now got is, yes, we have all of those examples and case studies that our providers are doing, but we've also brought in all of our colleges, the universities. There's things around what the Job Centre are doing, Essex Cares, different voluntary sector organisations. So it ends up being a 25-page document which really highlights the breadth of work which is happening around anchors and the opportunity to share learning. Over the summer, the most recent dashboard was completed around estates and sustainability. So again, what we'll do is we'll take that to the estates committee to get their feedback on how best we can use that information to produce the next impact report. So that's a really quick summary on the reports. The slide in the pack, which would be good just to very briefly talk on, is around the work we're doing around procurement and so our role as purchasers. So what we've done is we've brought together all the procurement leads from the providers. That in itself was a really positive meeting. We've had 2 meetings and it transpired that there isn't normally an opportunity for the procurement leads across the providers to come together to talk specifically around anchors. So we've decided that we're going to keep that meeting running. And we were looking at 2 specific things. One was around local spend and the other was around social value. So around local spend, there was discussion around acknowledging that actually determining what local is really quite complex. What local means for West Suffolk Foundation Trust will be different to what it means for EPUT. And so actually what we were saying is there's something about an East of England view and also a hyper-local view. And there was agreement that many of the providers have already carried out reviews of how much spend is local, but there was an agreement that a shared methodology would be really beneficial on that. So there's work which we're going to progress around that. The other thing we was looking at was around social value. There was agreement that in terms of embedding social value, there's quite a lot of work to do around actually ensuring that our staff and colleagues are really all on the same page about what we mean by social value. So we talked about social value training. I think it's fair to say that because there is that requirement that within all procurement, there is a 10% weighting of social value. It could be interpreted that, we've got social value covered. We know we've got that 10% in there. So that's sorted. But we know there's lots more we need to do. So there was discussions around how do we manage the tracking of social value commitments once those contracts have been awarded, and thinking about, is there a consistent approach to that? We're also thinking about the impact that social value and procurement processes have on the voluntary sector. So in many ways, you could think, well, social value, that's great for the voluntary sector. This is what they do day in, day out. But of course, from a procurement perspective, what they actually need to be able to do is think about how is this in addition to the work which they already do. And also some of our procurement processes can actually present barriers for our voluntary sector. So for example, providing carbon reduction plans and things like that for those smaller organisations can actually present barriers. Andrew Urquhart, who leads on sustainability, is part of the Anchors Programme Board, and he's really keen to think about how he can help support some of that work. So we are going to take something forward with the voluntary sector through the Assembly. The other thing we talked about is tools and software to monitor social value. And again, we're exploring, is there the potential that there might be an adoption of one form of program which helps to measure that, and whether we look at purchasing that software across all of our providers. So it's fair to say that we've had 2 conversations, 2 meetings so far. There's more work to do, but as a programme board, they're very much committed to how we prioritise that area around procurement at the moment, as well as continue that work around the dashboards. Thank you.
Rachel, thank you. And is it fair to say that with the final set of dashboards for procurement and communities being completed towards the end of the year, we as a board can expect the update on that and the impact report in either January or March?
Yes, it would be fair to say by the end of the financial year, all 3 impact reports will
Great.
be completed.
Okay. Let's take that as agreed. Now, Ewan, I think you said you had a very quick update from the board's perspective.
Yeah, just to make a couple of points. I think, just to highlight the value of this programme, bringing together all of the various pieces of work that are being done across the system, and the sharing of really good practice between partners. And I think the second point, really just to acknowledge some of the difficulty in prioritising some of these pieces of work with the other significant challenges we've got in the system around, for example, finance and operational delivery.
Always a challenge, isn't it? Always a challenge. So shall we as a board today receive and note the report, look forward to the final reports by the end of the financial year, so that with maybe if we could target March for it, Rachel, I think that would be good. Agreed? Oh, Elaine, yep. Go on then, yeah.
So forgive my ignorance, but because I appreciate a lot of this is about embedding social value that you refer to, and I think I understand what that means. But what would be helpful is if you could perhaps just give a couple of practical examples, how that makes a difference to the people in the community. I think that would help me be sure that I fully understand what we mean by embedding social value.
When the reports come back.
Okay.
Would that, can we do it that way around?
Okay.
Yeah. And
no,
have a chat outside the meeting.
Yeah, I think that'd be helpful to make it quite explicit.
Let's take that as an action. Yeah. Okay, thank you. Agreed. In which case, we've got the next steps there, and I'm going to go back to you, Rachel, and Kirsten for the VCSE paper. So, all yours.
Thank you very much, Chair. So thank you for inviting us today to give you an update on the Voluntary Sector Assembly and some of our key pieces of work at the moment, which includes the Resilience Charter and the Good Practice Guide. Just for context, you'll know that the ICS welcomes the voluntary sector as an equal partner, and this work is our way of trying to really embed that in the system so that the voluntary sector is an equal partner. Really important because, as we know, the voluntary sector is a really key provider, if you take it as a whole, of health and well-being services to our population. So it's really key that we are at the table and, you know, a key partner. So the first thing I wanted to mention was the Assembly, which has been set up in the last 18 months. I can't believe it's 18 months, actually. We only just had our 12-month review, it feels like, but it's going really well. We've got about 130 individual voluntary sector organisations who are members. And the point of it is to bring us all together almost like a quasi-organisation so that we can have a conversation and an opinion about key issues, but also, very importantly, to be able to host our ICS partners to come and talk to us about key issues that are going on and strategies. We've had some really good conversations, especially over the last few months. We've had the Urgent and Emergency Care Forward Plan come and talk to us, and we were able to feed in some issues that pertain to the voluntary sector that perhaps hadn't been really thought about. So I think we're making a difference in that way. We've got some great presentations coming up in the future. We've got NSFT and EPUT coming along to talk about mental health, as was mentioned earlier, really key for the voluntary sector. So I think really good stuff is going on. What I would say is there are still things to do, though, with the voluntary sector, and a couple of the items that we're talking about, the Resilience Charter and other bits. We have actually agreed as an ICS, so the ICB and the county councils have agreed and signed up to the Resilience Charter, and that's great because it really is fundamental and underpins all the work that we're doing and our ability to really become equal partners. But I would say there's still work to do on embedding the Resilience Charter, and if you could sign up to anything today, it would be to help us to really push that in your organisations and make sure we have embedded it, because it is the foundation and building block of us becoming equal partners, but also I think it's the foundation and building block for future shift in terms of what the voluntary sector can provide. So I guess today what we need to do is look at how well we're doing embedding those two things, where there are things that we need to improve on and where there are real successes. And for that, I'm going to hand over to Rachel, who's got the details.
Thank you. So in terms of the assurance processes, there's a couple of ways which we're doing that. And I think the assurance is really important because this work, it takes time, and there's a lot around those relationships and trust which we are looking to build and improve with the voluntary sector. The assurances of being able to say, well, so what are we doing about it? It's really key. So there's a couple of things we've been doing. So the first one here was in NHS England. It's called the Quality Development Toolkit for Embedding Voluntary Sector in ICSs. So it's not the shortest of titles. We often refer to it as the QDT. So we put ourselves forward last year as one of the pilots to do this. And just, I guess, the quick summary of it is that, as a system, we adopted it really well. We find it really helpful because we ran it at the same time as doing our Resilience Charter work. But when we reflected on it, we said, yes, it was fine, but actually there's more we could do. We felt that it didn't really meet some of our actual ambitions that we have within a system about how we want to progress the relationship with the voluntary sector. We also felt that actually, if we was to do it again, we'd like to do more with involving our neighbourhoods as well. So as we're now running this a second time, and that's not an NHSE sort of guidance, that's something we've decided to do as a system, we've kind of taken that first template and tweaked it so that it reflects what we need. And it was really good working with some of the locality managers who gave some feedback on the best way to do that. So basically what we've done, and we're still going through the process, it isn't finished. You'll see I don't have any figures here yet for Ipswich and East Suffolk, because we're going to be running those sort of in September and October. But basically we started by doing a session with our neighbourhoods, and we explored those 6 questions, which you can see there, around relationships, around funding, around working together, around training. So we're running those sessions first at neighbourhood level. So far we've done those in North East Essex and also West Suffolk, and it was really great feedback. So I think so far we've probably worked with about 40 voluntary sector organisations already. The next stage is we then take it to another colleagues within our voluntary sector and statutory organisations. And one of the other key things which we're doing, which we didn't have last year, was around going, what's the action plan? So we've got all of this information, what are we doing with it? So that's, again, one of the key things which we've taken forward. So this is just a really quick summary of some of the work which we've done in the alliances. So this first one is around for West Suffolk Alliance at neighbourhood level. I think the things which really shone through those conversations was about the strength of the relationships which are happening at locality level, those locality meetings and groups, which are, some of those are quite early in their stages of sort of being embedded, but really positive feedback. And one of the conversations was about, is the voluntary sector involved in strategic decision making? And they kind of reflected and said, well, at the moment, those locality meetings feel like an opportunity to be part of the conversations, but perhaps it's more about sharing information. But we know that as that evolves, that really does feel like the place where we can actually influence and have conversations at a strategic level. In terms of North East Essex Alliance, what really shone through on those ones was about the strength of the relationships. I think we had about 25 voluntary sector organisations who came to that neighbourhood meeting, and they all spoke very strongly about what strong relationships they have with their commissioners, with their partners, and how it really felt like a really collaborative way of working. As I say, well, we'll be able to report back on Ipswich and East Suffolk as well in coming weeks when we've run those sessions. So that's one of the first things we've been doing around our assurance processes. Then the next one which we've been doing is when we developed our resilience charter as part of the co-production and involvement with the voluntary sector, when we would ask them what does good look like in terms of a funding experience, they would often talk about the lottery or some of the community trusts and foundations. And the thing which is quite similar to all of those foundations is they all align to something called the IVAR UK principles, which is about open and trusting grant making. So what we did is we said, well, how do we take something which works with voluntary sector and see how we can embed that for our statutory partners? So we developed a good practice guide to funding and procurement. And part of the assurance process, which IVAR use, which we've also adopted, is there's a self-assessment process which our statutory partners do, and then we also run a survey. So we've run that survey over the summer, and this is just a few of the findings which have come back. We knew that it wasn't going to be necessarily the most easy of reading. We know that there's some good work happening, but we also know that we're still early on in this process, and there's still a lot of work to do. So this slide here, what it basically shows, one of the questions is, what change have you seen since the Resilience Charter has been adopted? And the reality is that for most people, they said there's either been no change or very little change, and only some people have seen some change. So the reality is we know, yes, there's good relationships there, but there's a lot more work to do. The other chart there is looking at the specific principles which we've adopted within the Good Practice Guide and seeing how well we are working through those. I think things which we're doing well on is around human contact, around open and honest relationships, and that is a really key part of the Resilience Charter. But there is more we need to do in terms of having more conversations about how the experience of the procurement process is, and thinking about how we can still think about the proportionality of the way we monitor and report. And the next slide is around, we asked a particular question which often comes up in our assembly, which is, do you feel like you are delivering services which are funded through statutory organisations which are over-resourced or oversubscribed? Or equally, do you feel like you're delivering services which actually should be funded? To talk through this quickly, there's not really much time to give to that, but there is a lot of responses which we've had from that. And often the things which came up around perhaps having long waiting lists, receiving some funding, but actually not for the level of roles which need to be funded. Often a common theme which is coming through is how our voluntary sector organisations are even using their charitable reserves or actually looking at additional fundraising to be able to develop the level of service which they need to provide. There's more work we need to do around this, but I think the survey gives us a starting point as a conversation to take forward in the Assembly. I'm just going to pass on to Kirsten, who can share some of the positive and negative experiences.
Thanks, Rachel. So in terms of what people actually said in the survey, there were some very positive experiences that they were having working with commissioners and with grant funders. And they really, I guess we can bunch them together. There were good open relationships. There's a lot of trust. And voluntary sector organisations are feeling that there is a recognition of the value that they bring, and also a sense of collaboration. And these are all really positive things. And I wouldn't underestimate how positive these are, because I think there are a lot of other ICSs across the country where that's not yet happening at all. So really good stuff. When you go on to the less positive experiences, and this is where we get a sense that maybe the Resilience Charter still needs embedding and we need your help with it. We're seeing a lot of excessive monitoring of contracts and funding being late, to the extent that organisations, and some of them are very small businesses, are worried about being able to sustain. And also the issue of full cost recovery. Funders trying to make savings maybe and not paying the full worth of a contract, which again can decimate a small business quite quickly. So those things, if people are saying they're still worrying about them, that suggests to us that the Resilience Charter still needs some work from all of us.
Thank you. Just to summarise, a couple of key things, which is some really positive work which we're doing. So in the east of England, there's a funders forum. So this is made up of a number of different organisations, from the National Lottery Community Fund, different trusts and foundations such as the Lloyds Foundation, Suffolk County Council, and numerous community foundations. And what that's looking at is how do we work more collectively, collaboratively around our funding? So acknowledging that the amount of funding that we have is a lot more reduced, and actually the demand for it is significantly higher than we've seen before. So how do we have a more joined up approach? This is something which came up when we was looking at our Resilience Charter, and it feels really positive. So this is the first steps of how we start to move that forward. So we have a group now established. We've set out some sort of terms of reference and how we're taking this forward. And I think within our system, I think we should feel really positive that SNE, due to the work we've done on the Resilience Charter and the relationships we have, we're one of those organisations that can really help to see how we can start to move this forward and think about, so for example, how is the grants which Suffolk County Council and the ICB and the community foundations all having a more joined up approach, thinking about how some smaller grants might be able to help some of that pilot work, which could then move on to the larger organisations once we have that proof of concept to provide that longer funding. So this has already been established in London. So we're looking at that as a sort of a blueprint, but acknowledging that how we work in the East of England is going to be slightly different. But we feel really positive about that. And I think SNE could be a really key partner in how we move that forward. And the very final slide is just to say that I think as a system, SNE, we are up there, when we're often asked to attend different networks and meetings to highlight the work which we've been doing. around, blogs, good practice, all of those things. As a system, we have very much adopted that principle that we do want to work with the voluntary sector, that they are key partners, but we know that there is still more to do. I think the funding survey and those kind of things shows that there's still a long way to go, but that's not to say that we don't have that commitment there. So really it's about how do we embed the Resilience Charter and how do we think about how we push ourselves to do more. Thank you.
Rachel, Kirsten, thank you very much. So a huge amount of work done and a huge amount of progress from the emerging and developing stages of 12, 18 months ago. But we still need to mature and embed, and you're asking for board support ongoing support and work in individual organisations to continue that embedding. So colleagues, any thoughts or comments or indeed disagreement with that approach? Elaine, yeah, thank you.
So not so much disagreement. I thought it was really useful going through it. The thing that did stand out to me, though, was looking at the survey and 70% of respondents saying that they felt that the funding should be statutory funding. And I found that quite, kind of a very high percentage. So I think for me, it was definitely cause for reflection and an area that I think it would definitely be good to see more coming back in terms of should there be a shift, between the way statutory funding is given to the way we do it today. So I think it'd be good to be more cited on that and get underneath it and understand better what action is needed to address it.
Yeah, and I saw you both nodding about that. Could I encourage you to have a conversation about that outside the meeting? Because I think that would be really useful input. Thank you. Peter.
No, thanks. I'll just welcome the report and the approach, really. And I think it gives us a really structured way to share different practice across the alliances and to learn from each other. And I think the other thing I'd do is just perhaps give more prominence to the district councils and borough councils in their role of commissioning, because I think they're probably the key with the county council and the local district councils and the NHS is that triad that are doing most of the statutory funding. And so we are certainly trying to do as much as we can in that area to kind of be more coherent in the way that we commission from voluntary sector. And that also includes, obviously, the way we commission from the hospice sector they're a significant part of this, and we're working really closely as a strategic level across the ICB to give how we can do that more strategically with that partner.
Good points. Yep, agreed. So, colleagues, we're receiving and noting. And as a board, we are collectively and individually supporting the continued development and indeed the embedding of this process. So let's call it exuberant support for the process. Yeah, all agreed? Thank you very much. Thank you, Rachel. Thank you, Kirsten. Item 13, finance report. Howard.
Thank you, Chair. So I'll take the report as read and highlight key areas and updates for the board. So my usual start, just a reminder to the board that when I use the word system, in this context, this report refers to the formal ICS partners. So that's the ICB, the Ambulance Service, ESNF, and West Suffolk Foundation Trust. The SNE system has an approved balanced financial plan in line with our £2.4 billion of funding allocations, and amongst the system partners, West Suffolk have a board and NHS approved 15.2 million deficit plan, which is offset by surpluses from other partners, predominantly the ICB. And this deficit was planned to be halved by 2025-26. In summary, at month 5, so that's the period into the end of August, the ICB Ambulance Service and ESNF have projections that are currently on track to deliver their approved plans. Noting pressures and risks outlined in the report, which are again in line with those reported into the July board. They include the rising costs associated with continuing healthcare, the strategic developments at ESNF, including the electronic patient record, the orthopaedic centre and green surgical hub, and the impact of industrial action and funding of the pay award. I can also report that the commissioned financial diagnostic for the ambulance service is on track and nearing completion. The highlights of that were presented at the last Finance Committee, and the final report will be going to Finance Committee in October with formal recommendations for approval at the ICB board in November. The report is intended to be a proactive measure given the rising financial risks for the ambulance service in the context of challenges to meet performance standards. The position at West Suffolk remains our most significant financial risk for this and next year. As of month 5, the Trust had a year-to-date deficit of £13.9 million against its approved plan of £15.2 million deficit for the full year, so with 7 months remaining. At this rate of expenditure, the Trust is heading for an unmitigated deficit of about £33 million. That would be £18 million off plan. And in order to deliver its plan, the rate of expenditure would need to reduce by some £2.5 million per month for the remainder of the year. The Trust has put forward a recovery plan with mitigations. This is projecting a range of between £28 to £25 million deficit, so £13 to £10 million more than plan. And we received the full financial recovery plan yesterday, which will be formally scrutinised at an extraordinary ICB Finance Committee to take place on the 1st of October. Next steps and immediate actions, including the system response, will be discussed at that meeting, which will also include the chief execs of the ICB and West Suffolk. So at present, I'm unable to comment on the contents of that report. I can, however, say something about just some immediate mitigations. The first of which is that there will be a very clear expectation from our regulators that the SNE system will need to meet its overall financial plan. So that in effect means that up to an additional 13 million potentially of funding will likely be needed to support West Suffolk's position in 2024-25. This is already over and above the 15 million already provided. Restrictions imposed upon us against some of our budgets by NHSE mean that these system solutions will require some challenging decisions and will all be non-recurrent in nature. And then given the other pressures we've had to consume this year, including CHC, our flexibilities are significantly reduced. So all solutions, if they can be found, will therefore include stopping some investments and inevitably lead to a far higher level of financial risk as we move into this and next year, and potentially cause restrictions on future investments and put at risk some £30 million of capital and revenue incentive funding if we are unable to deliver our system balance plan for this financial year. In the meantime, the ICB continues to have in place an additional layer of cost control approval for both pay and non-pay per approvals given at the ICB board in July. This is known as double lock. An update on the effectiveness of this measure will be reported formally to the ICB Finance Committee in October and then reported to this board along with any recommendations or amendments for the terms of reference. And then similarly with the review and discussion around the financial recovery plan following that 1st of October Finance Committee, recommendations will be made there and ultimately require ICB board approval, likely for November, Chair, depending on where we are in the cycle. Just also wanted to make a quick note that a draft 5-year financial plan was also presented at Finance Committee this month, and just to acknowledge really that there is still, I think, a significant amount of work to be done on this, including better triangulation with workforce performance, the strategic plans, and of course we are still awaiting for notification on allocations and operational planning guidance for next and future years. Further updates will be taken again through Finance Committee, and I will provide for an update to the board on progress in November. I'll stop there, Chair, and take any questions.
Thank you, Howard. So a huge amount of work in progress, and I think we can expect a much more detailed and perspicacious report in November following the Finance Committee work. But Ewan?
Yes, I just wanted to just correct one inaccuracy in the paper where it talks about the weekly vacancy approval panel having been suspended and no further posts being approved. That's not correct. There are clearly significant controls on approval of workforce, but the panel continues to meet on a weekly basis.
Okay, thank you, Ewan. And Chris, did you want to come in from a Finance Committee point of view?
Yeah, thank you, Chairman. I just wanted to add that the committee has spent a good amount of time looking at the challenges from the West Suffolk financial situation, and the extraordinary meeting on 1st October will indicate the direction of travel in terms of how the finances are going to land. And there is a lot of work to be done on the 5-year projections as well, because what we have seen now appears to be an older version, and there's been considerable change since the previous numbers were calculated. So there is a lot of work to be done on 1st of October and the next October Finance Committee meeting before we bring to the November board meeting.
Okay, yeah. And it may well be, Chris, Howard, no doubt you'll advise me, but if we need to call an extraordinary board meeting post these said meetings, then we can do that.
Some of the dependencies on the system solutions will require NHSE approval as well. So again, it depends on the timing of whether we can do that in October, but in November, I would say.
But certainly for November, yeah. Okay. Any more questions or comments? Were you done there, Howard, as well? So a lot of work in progress. Ed?
Yeah, I'm just stating the obvious. It's obviously a finance committee issue, but it's as much a quality committee, performance, etc. So not just within the trust and the alliance in West Suffolk, but it has implications for the entire system.
Yeah.
So we just need to think of it in the round and how we manage through going forward.
Absolutely. Good point. Well made. Yeah, absolutely. Noted. Thank you very much. Howard, I'm going to stick with... Oh, sorry.
Did you want to deal with the public questions under that item?
Oh, yes. Maybe we should do that now. Yeah. How do we want to do that, Tom?
So there are ones from Andy Benson.
Oh, yeah, that's right. The 4 questions from Andy Benson on SNF and industrial action. Who's going to read those out? Ruth, are you? Oh, is Andy? Are you with us? Okay, over to you. Yeah. Sorry, yeah. Couldn't see you behind the camera there. Yeah, go on. Yeah.
Words, my God, so many words. I don't know how you do it. You're probably completely exhausted by now, so I don't know whether you'll even be paying attention. Before I'll read my questions out, but can I just say a couple of things in advance, really, because I think it's about the context in which these questions are put. I was assuming before I came here, I'm Andy Benson, I'm from Suffolk, Keep Our NHS Public group. And when I came here, I assumed that you all knew about this dispute at Ipswich and Essex. But given some aspects of the earlier discussion, I'm now beginning to wonder whether you actually do know about the dispute and the strike and the proposal to outsource self-services within the trust. And I was a bit alarmed by Howard's response to an earlier question, which was about the ICB don't get involved in the management of their own contractors' contracts. Well, of course, that's true, but I think I don't need to remind you all that despite your powers of delegation and the principle of subsidiarity, ultimately the buck stops with you. And the discussion you just had about the finance at West Suffolk Hospital is a good case in point. If that continues to go belly up, the buck will come back in your direction. And I think I want to say that is true about outsourcing and privatisation of directly managed NHS services. It's not a small issue within the Foundation Trust over there. I mean, we're talking about something like 1,200 people involved, soft services, portering, cleaning, catering. Ipswich is already outsourced, has been outsourced to a group called the OCS Group, which is ultimately owned by a hedge fund in the Cayman Islands, which some of us have an opinion about. You may share that opinion. I'm quite sure that the people who run the outfit in the Cayman Islands don't really pay a lot of attention to the standards of cleaning in Ipswich and Colchester Hospital. But there we go. The reason that I'm wanting to interest you in this issue is not to invite you to manage SNF's contracts, but to understand that this isn't just a management issue, this is a strategic issue. that comes back in your direction. And consequently, this is what I'm wanting to do with these questions, is to confirm or otherwise the extent to which you as a statutory body with some responsibility in this arena are actively involved in or even monitoring the conversations and discussions that are going on over there about this particular outsourcing proposal. And that's what my questions are designed to elicit.
Perhaps I could encourage you to ask the questions.
I
Andy.
think I will. That's probably a good idea. I'm adding to the number of words. So these are the questions. Has the ICB viewed and considered any SNF business case reports on the proposed outsourcing of sub-services? If so, what view has been taken about the proposal? A copy of any available minutes or record of discussions would be appreciated as us in the public domain. Number two, that's the proposal to outsource the services that are currently directly managed. Number two, is the ICS aware of any business case reports on any option to take back in-house the OCS group contract at Ipswich Hospital and to continue to employ directly managed staff at other sites? If so, has the ICB considered such a proposal, and what view has been expressed on this option? Again, a copy of any available minutes or record of discussions would be appreciated. Three, if any of these reports exist and you know that they exist, please confirm whether they have been withheld from the public domain. And number four, in view of the industrial dispute and consequent disruption to services and patient care as a result of SNF's insistence on continuing with the outsourcing proposal, is the ICB in a position and willing to intervene in the proceedings?
Okay, thank you, Andy. Howard, I think you're going to deal with those.
So it's a statement, I suppose, really. But so the board's view is that the system's top priority remains patient care and safety, and we support SNF's commitment to making sure everyone who uses its hospitals and full range of services continues to receive the best care they can expect. It's the ICB's understanding that the full business case has not yet been submitted to the Trust Board for consideration. And the ICB, to repeat from the previous question really, does not manage Colchester Hospital, and the decision on how best to provide safe, effective and efficient services remains with the Trusts Board. And we understand that SNF remains keen to engage staff and its staff side colleagues, including Unison, so local patients continue to have access to the best possible services. The ICB board fully supports that position.
Okay, thank you very much. Thank you.
Nothing to do with you lot. Nothing to do with you lot.
I'll call a stop there, though, if I may. I'm going to move us on to the next item, which is the item 14, the annual report and accounts, which has already been approved by the board and to note today. Over to you, Howard.
So I'll comment on the production of the annual accounts, although of course the annual report covers matters including setting and delivery of strategy, key performance targets, quality, the green agenda, etc. As you just said, the annual report and accounts have been approved at a June board, which was held in private due to the restrictions around the general election, and they are coming here for noting at the public board. They have been prepared for the 2023-24 financial year, and the accounts have been audited by our external auditor, EY. The annual reports and accounts were reviewed at the ICB Audit Committee on the 17th of June, where they were recommended for approval. There are no material changes to report to the board since then that would change the recommendation from that Audit Committee. And the audit has confirmed the following, that the ICB has met its financial performance targets, including its duty to spend within its resources. The accounts represent a true and fair representation of the ICB financial position. The effect of any unadjusted audit differences are immaterial both individually and in aggregate to the financial statements. And EY have therefore issued an unmodified opinion of the financial statements, the regularity of expenditure and value for money. I'd just like to extend my thanks as ever to the ICB finance team and indeed the wider ICB team for their diligence and professionalism, and also my thanks to EY. We've really noticed a significant difference in the smooth operation of the audit this year. So, Chair, the board are asked to note the annual report and accounts and the letter of representation following the approval already provided in June.
Okay, thank you. So already approved on the 25th of June. In public meeting today, asked to receive and note. Received and noted. And thanks to all. Thank you, Howard. Item 15, integrated performance report. So how are we going to deal with this one, Ed?
Well, I think in the interest of time, we probably note it if that's okay, Chair, and if anyone has any specific questions, we could go to them.
Any questions on that report as submitted? Otherwise received and noted. Thank you very much. Item 16, the BAF. Amanda.
Thank you very much, Chair. So here we have our September Board Assurance Framework. And since our last meeting in July, a lot of activity has taken place and continues in terms of active risk management, led by the relevant director lead and primarily being channeled through the relevant subcommittee of the board. And by way of example, in August, the Quality Committee had a workshop and focused its workshop on 2 specific risks around ambulance handovers and corridor care, which is mentioned in paragraph 2.2 of the report. And the Quality Committee is planning further deep dives into other quality risks during October, and Lisa may wish to add a bit more at the end of this presentation. And then looking to the other risks which we have mentioned on the BAF, last week, by way of example, the Estates Committee met and considered 2 risks relating to RAC and climate change as 2.3. And the Estates Committee agreed that this would be a standing item at every board meeting where collectively and together they have agreed to manage and mitigate the risks going forward, which will be further updated in forthcoming board reports. With regards to primary care, we heard a lot from Maddie earlier relating to risk number 10, and we know from that conversation there are further work to be done around extending that risk to be more explicit on the estate challenges going forward, and that will be an action taken from myself and Maddie from today. But with regards to risk number 10, there is further conversation and more at the Primary Care Commission Committee, which is scheduled in a few weeks' time. And then moving to the people and workforce risk, we have People Committee coming up on the 16th of October, and this will be another agenda item where together we will be looking at the workforce risk and questioning, is that right? Does it need to be changed? Have we got the risk appetite and the like right going forward? So there's further work there. So in summary, Chair, and relating to section 3.1 of the report, I hope you will agree there is further work now being scrutinised within the subcommittee level, which is really supporting the directors and myself in proactively managing our risk agenda going forward. Underpinning the BAF, of course, we have the Risk and Resilience Group, and they are due to meet in a couple of weeks' time, early October, and they will continue to look at the risks at directorate level. My final comment, Chair, which I have not put in the report, but I think it's something that we should consider today. A year ago, we had a board development workshop on risk management. And given we've done a lot in terms of proving our approach to risk management, and indeed learning and continuing to learn from recent audit reports, I would like to recommend that perhaps early in 25, we have a further board development session whereby collectively we can really start to understand what more we need to be doing to strengthen our risk management agenda. And that would actually be in good timing given we want to update our risk management strategy anyway. Okay. I will leave it there, Chair, but invite other directors to add if they wish. I'm very happy to take any questions.
Thank you, Amanda. So proposal is for early in the new year, did you say, Amanda? A focused, dedicated risk management development workshop to take us to the next stage. Yeah, okay. I didn't see anybody disagreeing with that, so we'll take that as agreed unless anybody speaks against it. Howard?
Just to say on risk 25 and the financial risk, we'll obviously need to update that.
Yeah.
post the next finance committee.
Yeah. Good point. Noted. Yeah, Kath?
Thank you. I'm just thinking about risk number 10, which is about access to primary care and whether or not part of the work that's planned relates to the impact of the collective action that's being discussed and that was mentioned earlier. And I'm thinking particularly in terms of impact on the population themselves in accessing services, whether or not that has an impact on the confidence of the population in primary care and how they can access that, but also the impact on other organisations as a result of the selection of that collective action and what that might mean for other partners within the system.
Yeah. Okay, can you pick that up outside the meeting and feedback on? Noted. Good. Thank you. Any other points? Otherwise, with the next steps as articulated by Amanda and Howard, indeed, because that might be an interim update, might it not? Received, noted, approved. Great, thank you very much. Item 17, the ICP update. Now, Susanna's had to give apologies today for very good reasons, and we wish her well, of course. But what I suggest we do is, Rachel, could we ask Susanna to draft a one-page summary and that we circulate that after the meeting? Yeah, thank you very much. Happy with that, Tom? Okay. Item 18, Audit Committee Annual Report. We're here today to approve and endorse it. Janet?
Thank you very much, Chair, and I'll be very brief. Obviously, a huge part of the work in the last year has been focusing on the annual report and accounts, both for 22-3 and 23-4. I'm glad to say we're all up to date there. We've got an extensive internal audit programme which looks at the design and effectiveness of all our control systems. We've had a lot of input and effort into the risk and assurance arrangements that Amanda has spoken about a couple of minutes ago, and we'll continue to support that work, and with a view to it being a really effective board assurance framework. There's also going to be some ongoing work around system risks as well, because we have organisational risks, systems risks, and some are both and some are one and the other. So we've got some work to do, development on that.
Which plays into the workshop.
Which
dedicated
absolutely
workshop.
plays into the conversation in the workshop, which will be about our risk appetite as well, which is a very important conversation we need to have. So the audit committee will continue to work with Amanda and the team on design and implementation of that. And then just finally to say, we've got some practical issues in the new financial year, which is a new finance system, which Howard's team will be working extensively with, and don't underestimate how time consuming that will be for teams. So audit committee will keep a remit on that as well. So happy to take any questions anybody has.
Thank you, Janice. Any questions? Otherwise, received, noted and endorsed. Agreed. Thank you very much. Item 19, the amendments to the Constitution and committee terms of reference, which have either been mandated on us by NHS and or have been through the committees already and approved, Amanda, haven't they? So over to you.
Thank you very much, Chair. So very briefly, we have 3 requirements of this paper. One, to accept the changes that we are mandated with regards to our Constitution, and for ease of reference, those changes are appended to the back of the report and shown in red. The second is to support 3 terms of reference which have been updated and considered by the relevant committee, i.e. Equality, Estates and People Committee. So we are required to hopefully endorse those decisions. And the final, as part of our Constitution, is that we are now able to proceed with not 2 new roles, but 2 additional responsibilities for our board, which are around the deputy chair and senior non-executive member. And we have a paper going to our remuneration committee in October that is going to articulate the nomination process. And from that, we will then bring back the outcome of that to our November board. Thank you, Chair.
Lovely, Amanda. And all changes proposed are track changes in the papers that you've got and read. Any questions on them? Any disagreements? All noted, received, noted and agreed? Done. Thank you very much. Item 20, the committee minutes and highlight reports. Should we just go straight for any questions on any of those papers? So They are to receive a note and 4 questions, but if there are none, shall we say received and noted? All done. That's good. Thank you. Attendance log again. Any questions? Otherwise received and noted. Done. Any other business? None notified to me prior. I'm just looking around the table. Wave at me if you have any. Otherwise, no other business, which takes us to questions from the public. Now, Tom, you help me with this. Oh, yes, Mike, let me come to you first, because I know you're... Oh, it's Barbara as well, isn't it? Yeah, I'll come to you. You go ahead, Mike, because I know you want to shoot off, don't you?
Yes, I need to.
Yeah.
Good afternoon. Very informative. Many words to read, I think, from your meeting today. I'm here really on behalf of community health particularly, but initially I'd like to inform you that East Suffolk District Council is starting preparatory work to review its local plan. I doubt whether many of you are aware that East Suffolk District Council actually covers 2 ICBs, yourself and Norfolk and Waveney, which makes that task somewhat more difficult. But I did review the Suffolk Coastal local plan, which this one will replace, and I was very surprised at the lack of any health input within that local plan, bearing in mind that local councils are responsible for housing, particularly recreation. There should be much more engagement, certainly at the community health level, with the local plan, and it needs to be at the beginning stages. Particularly, you made reference to the estates that the NHS has, and often you're behind the curve in that you make it a part of a CIL, Community Infrastructure Levy bid, rather than it being a requirement of the scheme. And I've just, a meeting I should be at this afternoon is education. And within education, you have sums of money placed against pupils for primary school, secondary school, sixth form expansion, early years expansion, libraries, etc., etc. And I'm not sure whether that is done by Maddie and colleagues, but it's something that should be there. And for every application that we will review or receive, there should be some funding coming not only for you, but in our case, we are concerned that the expansion by over 10,000 folk on the Felixstowe Peninsula will put additional demand upon our community hospital, which currently is primarily used as a relief valve for Ipswich Hospital. It doesn't really function as the community hospital that we all expected when it was agreed back, I think, in 1998. So there are areas where we should be working together for the benefit. And if we go back to the King's Fund of February last year, that stated there should be much more involvement with local councils.
So,
And
Mike,
your
can you articulate the question though that you're asking?
Well, I suppose what I should be saying is what engagement is going to be made in view of the fact there is an opportunity coming, because the local plan will be underway very shortly, and we're all aware that we have a new government and that will be changing an awful lot of things. So we need to get that before we start.
So it's both a challenge and an opportunity.
Pretty much, yes it is.
Maddie, could I ask you for a quick response on that?
Yes, thank you. So obviously we've been working very closely with the Suffolk Council with regard to the Felixstowe practices, and there will be a formal announcement shortly on the work that has been agreed and the development of additional capacity within the practices. We met with the Chief Executive and the Head of Planning last week, and we will be meeting in a workshop together to assess all of the additional proposals as part of the plan and our collective response. So I think there's an absolutely excellent partnership in place between the council and ourselves, and that will be shown in the plan as we progress. Thank you.
So I think the other point is it's not only your ICB, it's also Norfolk and Waveney, because we are the biggest district council within England. The other question I would like to ask is the Suffolk Alliance, as Maddie has just pointed out, delivers care in the area in which I live, but I don't believe as of yet we've had a meeting in public of that particular organisation. Does the board expect to be doing that across all the alliances so there's more engagement between the alliances and the communities they serve? Thank you.
Okay. Maddie?
So I'm happy to answer that as well. Thank you. So we did have an event planned in the summertime. I think that was postponed. I was trying to remember when you asked me previously. I think because of more local elections previously, we continue to have open events within our integrated neighbourhood teams, and we remain committed to a committee meeting in public. So yes, is the answer. Thank you.
Okay, thank you. Thank you. And is that Barbara at the back? I'll just hold you, if I may, for a moment, Barbara. There's a question from Mr. Dooley. Mr. Dooley, one of your questions was on can we include a glossary of terms and acronyms going forward? And the short answer to that is yes. And I think, Tom, you're planning to do that from November. So hopefully that'll be helpful. There was an... Go on.
I mentioned that when I went to the meetings of the, whatever you called yourselves before, the ICB, it was agreed to produce a glossary of terms. So one certainly existed. I don't know whether it still exists, but it seems to me made sense to start with that and then to have regular updates. Because frankly, I've sat in this meeting in the previous one and I have no idea what we're talking about some of the time.
Okay.
Made assumptions. And there's one colleague in the room, and I won't mention it, who that person is, used two acronyms in one sentence. And I thought, I don't know what the hell you're talking about.
Well, let's see if we can try and help.
If you have a meeting in public,
yeah.
The public should feel engaged with the process. And quite frankly, what goes on disengaged.
Point noted, and we'll try and we'll work on addressing that. In the members of the public present, do we have Ivan Ambrose? No, we don't. Kath, there's a question come in from Ivan Ambrose. What steps have been taken to provide the adjustments needed for autistic people who are under the care of NSFT?
Yeah. Thank you so much. So at NSFT, we've got a network of green light champions who promote inclusion and support teams in order that we can then explore how to put in place reasonable adjustments for autistic people who are under our care. And this programme is led by Dawn Collins, who is our Deputy Chief Nurse and really experienced. So in terms of some of the steps, we've already mentioned the Oliver McGowan training that is put in place within our organisation. We complete the Green Light Toolkit, which sets out essentially where there are opportunities to help us to improve our services, and it gives examples of where we can make specific changes. We've got our Green Light Network, and it's a specialist interest group, and their job is to support the delivery of care to people with a learning disability or autistic people. All that information is available within the organisation to our staff on our intranet, so we've got very active communication network within the trust on that.
Okay, thank you very much. And Andrew, there was the question from Mr. Dooley around physician associates, which I asked to be held to the end. Do you have a response on that one, please?
I do, yes. Thank you, Chair. So the first thing I'd like to say about physicians associates is, and actually about all of our healthcare teams, is that all members of our healthcare teams are valued members of our integrated care system, including doctors, nurses, AHPs, and physicians associates. It is extremely important that all members of the healthcare team receive appropriate supervision and management and support, and that includes physicians associates as well as any other member of the healthcare team. Nonetheless, the comments made by the Royal College of General Practitioners over the weekend are significant, and I have to take them seriously and think about them. And I particularly support the college's position that they have released 3 sets of guidance for general practices to use around physicians associates, which may be helpful. And I'll be working with the primary care team to reflect on those guidelines produced by the college and how we can take them into account. Also, the context of comments from you, Mr. Dooley, about physicians associates and concerns regarding the training and supervision of physicians associates means that I've decided to do a bit of assurance work with Amanda, who's our Director of People, and with Maddie as a Sponsor Director for Primary Care, looking at how physicians associates are being used in our system, because there's an increasing level of concern they may not be used appropriately. I do not share that concern, but I want to be able to provide you with the assurance that you require.
Okay. Thank you, Andrew. So I think we have time for one more. And is that Barbara at the back? Yeah, go on.
Thank you. My question, I'll be brief.
You're on. Yeah, you're okay. Yeah.
Stress ball from Expo last week. It's been very useful. It's in regard to the governance review, which was referred to, but it also touches on matters arising and the quality outcomes reports you've had. We'd like support to have a look again at the governance of terms of reference and task and finish groups. We put in a complaint because we're not happy with the progress of our task and finish that we've been working on for 2 years. We received, thank you, Ed, a written response to our complaint to say that our task and finish group had ceased. Well, that's news to me. I haven't been asked. There seems to be some sort of confusion, breakdown, understanding, quite understandably. So what we'd like to do is revisit our terms of reference, our task and finish under the governance review. We think it's still active. We worked till May. We had an outcome which we were expecting delivery of. We've been co-producing for 2 decades and for 2 years intensively. And we would like to see a proper co-produced and co-delivered new service for ME and CFS if it's to be aligned with long COVID. Everything today with the reports we've had substantiates that's a good idea. It also needs to incorporate Health Watch's excellent surveys that have been done over the last 3 or 4 years to see where these services should be going and how they should be delivered. Good practice guidance as well. What we seem to have had is, and I don't know why, perhaps the board can ask, we seem to have a change in a specification and a pathway from the one that we agreed to or were about to sign off. It hadn't been fully signed off. We have a new version which doesn't and we can't agree to for many reasons. It isn't collaborative. It almost appears to be being altered to fit a different model and a workforce model that we can't agree to for ME and CFS. We have a reasonable budget and a reasonable opportunity and a reasonable hope that you will be the first ICB in the country with a 5-year plan for ME, CFS and long COVID to deliver ahead of the Department for Education's Department of Health delivery plan. Tomorrow we see the inquest outcome of an ME patient. Please watch it, board. We don't want that to happen here. It's harrowing. It's harrowing. We want to see a positive outcome. We want to see our task and finish through to finish to an agreement, best compromise, and we want board support in enabling that to happen. Thank you.
Barbara, thank you. Narinder, do you have any comments that you could quite quickly add to that? Am I right in also thinking this is the item that is planned to come to board in November, when we can have a more fuller debate on it? Yeah, okay.
Thank you, Chair. Morning, Barbara. Just to pick up some comments in terms of our co-production and our engagement continues around the service area, and we'll do so up until the 14th of October when we submit our executive paper. The task and finish group did conclude because it had come to a point where we needed to move it to the next phase where we were finalising the service specification and the model. We continue that engagement with current service users and those with lived experience. I think in terms of the task and finish group, as Barbara has pointed out, on reflection, there was probably an opportunity to have given a different level of clarity on the role and remit of that task and finish group, including what it was able to cover in terms of influencing the workforce model and the delivery model. We will share, and as we've said with Barbara and other colleagues, the inquest outcome tomorrow, we'll look at the impact of that very closely and significantly on how it might change what we've produced to date in terms of our model and service specification. But that work's ongoing, and as we've said, we will be bringing it to this board in November in terms of a recommendation for procurement of a combined service for ME and CFS and long COVID.
Okay,
Thank
Verinda,
you.
thank you very much. Colleagues, I'm ever so sorry, we're 15 minutes over. I am tempted to think that we ought to close the meeting. We've had our public questions. Did the gentleman in the front row, did you have one question that you want? Yeah, is it possible? Would you mind briefing the board in writing on that question, or brief it? Do you mind coming to the next board meeting to ask it? Yeah. Otherwise, we might not give you a fair crack of the whip today. No. You happy to come to the next board? Okay. Thank you. In which case, thank you very much for that. Really helpful. In which case, colleagues, let's close the meeting. Next meeting is the 26th of November. Thank you very much all. Meeting closed. Thank you.